Yeah, that'd be good. James,
You're like, you're not sleeping.
safety.
Just to remind y'all, we are being live streamed right now. Right now, you're on YouTube.
Is it all day?
Yes, it is all day. Yes.
Where is it?
How are we being last night? What's the
Tuesday view.
Morning. You're on the front row. Front row, graduates.
Morning. Well, that's good.
Do you think Shreveport escaped us?
One over here and then one over on this side. There's one on the middle, two. So like one there, one on the end.
He got that breakfast and loved to wife. He's not like me at Kevin.
Oh, that's top.
We all fought. Give all That's exactly how it makes it.
Oh, okay. Gotcha. So we
That's yours to wear. This is your presenter, and then you will have this one.
Oh, I missed it that night. I was willing to jump to my room.
I'm sure you were.
But it happened.
Yeah, I know.
This piece of shit was on me.
When was you teaching?
So we're going to depart to be there.
Probably Monday. Chicago, long drive.
She feels like, man,
Thank you.
call it and get together.
Oh, absolutely.
If they have a whole
Have one again. I know.
I got it.
How could there be anything other?
Telecom has outlined the guidance. You have one here, one behind,
Spoopy.
Yeah. Yeah. Never late on it.
There's gonna be some names that only me and you and Donnie and Kevin are gonna know, just a few of them. I'll go over the history. You'll remember them. Tonight, some of the
That's the top sitting there.
In 1962, I was in Yemen. I did this. They were not. They have not.
You and I were presenting cases on Tuesday mornings. Dr. Knight, Dr. Griffin, Chuck Knight. Boy, he was a stressful morning. God wanted everything just right for the town and gown.
They were
Just about
And the verbal war that often went on between Dr. Goldman and Leonard Goldman.
oh,
Yes.
yeah.
I have brought it in the car in case.
I was told like probably one more year, well, I'm gonna get to it has. You know, before we stopped there, we were very, very busy. Now we're starting to pick up. Yes, sir. And I hear that, that'll be a better edition. That'll be a better edition.
How is the patient? Have you seen the patient?
Yeah. Nice. Yeah, I definitely agree.
No, she makes them every morning. My brother played up.
Promise I'll get a haircut soon.
Put me like that. I don't know. You'll want that much hair when you get mine.
Oh, yeah.
Which one?
Kenny, we'll, just believe who's this? CDHO. John Roy. Oh, that's right. That's who I was looking at. That's right. welcome everyone. Our graduation day. This is the best time of the year. I think everybody would agree. Whether you have someone in junior high graduating or high school, but 5 or 6 years of training to me is a venerable time for you guys, and it's a very special time. As we all know, it's been altered unmistakably, not only here, but all throughout the nation. And after talking with other chairmen about how they're doing this, they're having to be quite inventive, just like we have. A lot of the regalia and revelry and eating and drinking hadn't been here, but I want you to know that we were here to give you a good send-off today and give you a chance to say the things you've been wanting to say for 6 years. So, our itinerary today, our agenda today, will be some case presentations. I picked 3 clinical case presentations over the last year that I thought represented our faculty the best, represented our talents the best, and represented how we could learn from advanced cases that we do. It differentiates us from the local population and differentiates us from the surrounding centers, the medical centers. So we'll have 3 of these cases. Then we'll vote. I picked these cases from what I thought were the best, but I want you to know that this is going to be an interactive day. So you're able to pick who you think, not only the best presenter, what's the best overall case, and how this case best represents LSU Health. We'll have a small break at 9:30, and then 9:45, we have 3 case presentations, resident research presentations that we've also voted on. We had a consortium of Dr. Chu and myself, Dr. Samra, and Dr. Larimore, who have picked what we thought were the best research presentations. And once again, at the end of those, I'll ask the audience by silent or anonymous ballot to send in their thoughts about the best presentations, research presentations. I'll give a lecture at 10:45 that I hope you'll find enjoyable. It's about the history of not only LSU Medical Center, but where we stood with charity care since 1876. This is over months and months of research that I've accumulated, some things not only in the city, but the Knoll Library at LSUS, our library here. You'd be amazed at what you can find online. It's already here about the history of our medical center, about the history of charity care, and also just perusing not only antique stores. Was able to find several old books from the Shreveport Medical Society, which antedates all of us near the Civil War, when that publication and that organization was actually up and running as a physician organization. So we'll take that through, and I hope you find that enjoyable and also educational. We'll have a lunch at noon, and at 1 o'clock, we'll present residence awards and also a faculty award, and it will, at that time, unleash our chief residents on their time, the time that they want to share with us. I think the goods and the bads, and the happies and the sads, and everything that they want to tell us before they depart. Without further ado, we'll start with the first clinical case presentation. Dr. Armstrong, Dr. Sugars, and Dr. Kim, right breast cancer, bilateral mastectomy with left reconstruction with tissue expansers. Dr. Armstrong. And if you can, if you feel comfortable to be able to speak without your mask at the podium, it would be nice so we can all understand.
Do I need to use this microphone?
I think so, yeah. Try it on for you.
Can y'all hear me? Good morning. Thank you for allowing me to present my case today. I'm Francesca Armstrong, one of the 4th-year surgery residents. I'll be presenting bilateral mastectomy with immediate left breast reconstruction. Thank you to Dr. Sugar and Dr. Kim, my attendings for this case. So briefly, this patient's a 37-year-old female who initially presented to an outside hospital with a 3-month complaint of a 5-centimeter axillary mass. She underwent a biopsy of this mass in 2018 at the outside hospital. Her pathology returned positive back for invasive ductal carcinoma and DCIS of the breast. It was receptor triple negative, and 2 out of 3 lymph nodes were positive for metastatic disease. Her stage at that time was T3N1, stage 3A. So she underwent neoadjuvant chemotherapy at the outside hospital. She did not complete this, unfortunately, due to adverse side effects. She was then referred to Feisweiler in 2019 to established care. At that time, when she was here, she noticed an increase in size of the axillary nodes and the breast mass after she had stopped her chemotherapy. So she underwent restaging workup, which was negative for metastatic disease. Her past medical history was significant for anxiety, a couple other medical problems. Her family history was significant because she had a mother and a maternal aunt with ovarian cancer, and she was also a smoker. On physical exam, her left breast had no abnormalities. The right breast had a well-healed incision in her axilla, as well as a 6-centimeter mass that was not fixed to the chest wall. Again, her restaging workup was negative for any metastatic disease. She did undergo genetic testing, which resulted back in ATM variant of uncertain significance. We discussed multiple surgical options with her regarding breast conservation therapy, right modified radical mastectomy versus right modified radical mastectomy with a left total mastectomy. The patient ultimately decided for bilateral mastectomy with reconstruction just due to her family history. So she was seen by plastic surgery for a discussion regarding reconstruction. The decision was then made to do an immediate reconstruction on the left side with delayed reconstruction on the right side after undergoing radiation. This is just a video of her PET scan. And you'll be able to see she's got some FDG activity in her breast as well as in her axillary lymph nodes. And no other metastatic disease elsewhere. So in the OR, we began with the left simple mastectomy. We did use SPY technology to verify our flap viability, which was well perfused. I've included a picture of SPY technology just for y'all's reference. This is not our patient, but you'll note here there's some decreased fluorescence. This is an area that's concerning for poor perfusion. After the left mastectomy was completed, we performed the right modified radical mastectomy. Dr. Kim then came to the OR to perform the reconstruction on the left side with a tissue expander. She had bilateral JP drains placed at the completion of the case, and she was admitted post-op for observation. She was discharged home on post-op day 1. Her pathology returned fibrocystic changes in the left breast. On the right side, she had metaplastic carcinoma with DCIS as well. The margins were negative on the breast. 1 out of her 6 lymph nodes were positive for metastatic carcinoma. I wanted to talk about genetic testing. So this has expanded largely since 2018. There's a Supreme Court ruling that required increasing testing options. Since then, there's been an improvement in technology that now allows for testing for multiple genes at one time, as well as lowering cost of testing. Panel testing increases the rate of detection of pathogenic variants, which I've listed on the slide. Some of the more common ones are BRCA1, BRCA2, PALB2, CHEK2, and ATM. Identification of these variants is important because it influences our high-risk screening, as well as risk reduction in therapeutic options in terms of surgery, radiation, and systemic therapies. The NCC guidelines currently for genetic testing are any individuals with a relative with a known pathogenic variant, anybody with a personal breast cancer history with 1 or more of the following that I've listed here. This includes age 45 or less, anybody age 46 to 50, either with an unknown family history, a second breast cancer, a family relative with breast, ovarian, pancreatic, or prostate cancer, anybody age 60 or less with triple-negative breast cancer, anybody with an Ashkenazi Jewish ancestry with similar requirements as before, family members with ovarian, pancreatic, prostate cancer, and any age male breast cancer. In terms of the variant of unknown significance, these are genes, DNA sequences that are still undergoing data collection to determine their definitive classification. They're not considered to be clinically actionable as they're inconclusive. And so when a patient develops a variant of, or has a variant of unknown significance, the recommendation is to manage them based on other risk factors. The next topic I wanted to talk about was post-mastectomy radiation therapy, or PMRT. So the benefit of this is a decrease in local regional recurrence. There's also an increase in long-term breast cancer specific survival and overall survival. The fields that are radiated are the chest wall, the supraclavicular and infraclavicular lymph node basins, the axillary lymph node basins, and the internal mammary lymph node basins. Indications are different for patients with and without neoadjuvant treatment. So those that did not undergo neoadjuvant treatment, the indications are for anybody with greater than 3 positive lymph nodes, any known negative disease with high-risk features, including T4 disease, positive margins at the mastectomy site, any other poor prognostic features, and select T2 and T3 tumors. Indications for patients with neoadjuvant treatment are anybody with residual nodal disease, residual breast disease, patients that had complete response with neoadjuvant that were initially stage 3, and any patients that met criteria for radiation prior to neoadjuvant treatment. In those that did not receive neoadjuvant treatment, it's been noted that certain populations have an increase in breast cancer specific and overall survival. These are women with node-positive disease, premenopausal women with node-positive disease, pre- and postmenopausal women, and then women with less than 4 lymph nodes involved. And these have all been done by different studies. In patients that did receive neoadjuvant treatment, there's lower rates of local regional recurrence at 10 years in patients that did have a complete pathological response with post-mastectomy radiation. The last thing I wanted to cover was Reconstruction. So the Women's Health Care and Cancer Rights Act of 1998 is a federal law that provides protection to patients that want reconstruction after undergoing mastectomy. This requires that coverage is provided for all stages of reconstruction of the site of the mastectomy, surgery and reconstruction on the contralateral side for symmetry, and any prosthesis and treatment of physical complications. It's been noted that reconstruction provides psychological, social, emotional, and functional improvements on these patients. There's an improvement in psychological health and self-esteem. Currently, only about 40% of women undergo reconstruction after undergoing mastectomy. There was an interesting survey from 2002 that showed at that time about 24% of surgeons referred more than 75% of their mastectomy patients for reconstruction, which is low. Patients were also surveyed, and the most common reason for not undergoing reconstruction was a desire to avoid further surgery. Reconstruction is associated with high levels of patient satisfaction. This is dependent on the type of reconstruction that they get, whether that be autologous or implant-based. There's different techniques. Like I mentioned, there's implant-based and autologous flat-based. There's also delayed versus immediate. Immediate is recommended in prophylactic or simple mastectomy. Delayed is recommended in patients that have inflammatory breast cancer, any patients with comorbid conditions that increase their risk of postoperative complications. The benefit of delayed reconstruction is noted in patients that undergo adjuvant radiation. Radiation causes fibrosis, capsular contraction after immediate reconstruction in about 30% of patients. So these patients tend to benefit from delayed autologous flap reconstruction. Implant-based can be 1-stage or 2-stage, whether that be with a tissue expander with plans to exchange for a permanent implant at a later date with the 2nd stage. Flap-based can either be a free flap or a pedicled flap. The most common flaps are the deep inferior epigastric artery perforator, or DEEP flap, and the transverse rectus abdominis musculocutaneous, or TRAM flap. These are just some pictures that I wanted to include to compare the two. So the DEEP flap is a muscle-sparing technique that uses a skin and subcutaneous tissue island for reconstruction. The TRAM flap does include the rectus muscle. Immediate reconstruction, as I mentioned before, can be considered in most patients with undergoing mastectomy. The advantage is a streamlined surgical process and overall cost reduction. The patients experience a better psychosocial effect because their body image is preserved. The disadvantage is a prolonged operative time. If there's any issue with concerns regarding flap necrosis, this can affect the aesthetic result. If there's any issues with a large tumor, dry skin involvement, the patient may require radiation afterwards, which can also affect the outcome. Delayed is indicated if there's any concern for tissue perfusion. It's preferred when patients are undergoing radiation postoperatively. Any patients with comorbid conditions that would place them at a higher risk for complications and inflammatory breast cancer. The advantage of a delayed reconstruction is you can assure that you have clear margins postoperatively, and it allows for completion of adjuvant treatment. The disadvantages is need for subsequent surgery. There's limited options after radiation, and there are reports of lesser aesthetic quality. In terms of integrating post-mastectomy radiation and reconstruction, it does cause some challenges. As mentioned before, radiation can cause tissue fibrosis and decrease the quality of the tissue. So there's a higher risk of post-op complications. It does require some coordination between multiple teams to kind of coordinate the best optimal time for the best outcome for the patient. These are my references. Thank you for your time, and I'd be happy to answer any questions.
Thank you, Dr. Armstrong. Well-researched. Nice case. Anybody have any idea what the compensation is for these flaps? Dr. Chu? Dr. Kemp?
Compensation in terms of
Yeah, for reconstruction. since there's an act by law, it seems like that the Medicare and others would follow, but I don't know that.
Well, I think in Louisiana, it was just within the past 5-6 years that they started covering the contralateral side. Because nationwide was supposed to be that they were going to cover both sides, because you can't have one very large breast and a reconstructed breast, and aesthetically and psychologically the patient did not do well. But when in Louisiana, it just became covered service by Medicaid and Medicare. Medicare covers it, but Medicaid, they did not cover the contralateral side. Reimbursement-wise, I mean, it really does not matter whether it's an expander or a flap. It just lands at the reconstruction. I don't know the exact numbers.
Do you find that most women opt for delayed versus immediate, implant-based versus free flap or versus pedicle flap?
Within the past few years, I've seen more towards getting immediate reconstruction. The women want immediate reconstruction. It is a bigger recovery, obviously, and it's a time-consuming process. Once we go over everything, some women do not want to go through the multiple surgeries. They want to wait. It's up to them, but recently it's been more immediate.
Sure. Dr. Sugar?
So one of the challenges for reconstruction for a lot of the patients is, even though the law has been there since 1998, one, getting it actually approved without going through multiple applications, and then it's approved by insurance, but to have a plastic surgeon in private practice who accepts that insurance plan or Medicaid. So even though the insurance is required to cover it, you may have trouble finding a plastic surgeon who accepts the insurance and is willing to schedule the case and see that patient. Because a lot of the practices are either cash-based or commercial only. And so we are actually very fortunate here that we do have Dr. Kim here and accepts the insurance plans for all of our patients. And so our patients do have readily available access to reconstruction.
Okay, thank you. Any other comments about this case specifically, Dr. Sugar?
I think in this case highlights actually almost all of the different aspects of preoperative planning between the genetic testing. Hers had the VUS, variant of uncertain significance, which isn't actionable, but looking at her family history of the mother and aunt with ovarian cancer and breast cancer in such a young age, that actually was the impetus for doing bilateral mastectomy. But then the coordinated planning, knowing ahead of time that you're going to do radiation, then affects your plans for the reconstruction and the surgery itself.
Sure. Debbie, Dr. Chu has a comment. While she's getting the mic there, it's been interesting in this lecture room to see the evolution of breast cancer treatment. I recertified in general surgery 2 years ago. It was the most difficult section for me as a thoracic surgeon, having trained in general and continuing to re-up my certification. Very difficult, very different. I think the genetic markers have revolutionized things and help with prognosis. So it's definitely a treatment and evolution, whereas you haven't seen that many changes, say, like in lung cancer treatment. Dr. Chu?
Yeah, I agree, and I think that for the oral boards, one of the favorite questions they're going to ask is a locally advanced breast cancer, because those who are not exposed to management of breast will say, I would proceed with a mastectomy, and that's where you would fail. I enjoy your presentation. Very nice, very thorough. I just want to pick your brain and kind of ask your thoughts. So we know that at least in the BRCA population, bilateral prophylactic mastectomy decreases breast cancer rate by 90+%. Irrefutable data. But the data clearly demonstrates that prophylactic bilateral mastectomy does absolutely nothing to overall survival. The key improvement in survival is a prophylactic THBSO. So extrapolating data from the BRCA data, and with this unknown variants, unknown how actionable it is with this hereditary defect that you identified, you proceeded with a mastectomy prophylactically. Have you thought about doing a prophylactic hysterectomy and bilateral sublingual oophorectomy? Knowing, again, from the BRCA data, the only survival benefit is a prophylactic THBSO. Because I think that it is great that we do all of this. Reconstruction is very nice, but at the end of the day, it is a survival benefit that we try to achieve. So what are your thoughts about that?
So I think because she was not a BRCA patient, I don't think the prophylactic hysterectomy, oophorectomy came into consideration. I think it's something certainly to be looked at. But I guess for her case, it was a little different because she had a different genetic mutation and a variant of unknown significance.
But I would argue that because you use the data from the BRCA to justify bilateral prophylactic mastectomy, then why not use that data to extrapolate for the hysterectomy part also?
Right. I think that's a fair point.
Dr. Sugar? Debbie, we're going to keep you running today. I think Dr. Sugar.
Can I ask a brief
Please.
question?
Yes, please. Thank you. I'm sorry.
Congratulations. I think that this is very nice summary, excellent presentation, good quality slide. My only question, 12 years ago, my wife had mastectomy done, and I look at the specimen, there were 32 lymph nodes, only 2 positive. I know that there were only 6 here. Why is that the case?
So she had undergone, initially the outside hospital reported that she had undergone an excisional biopsy before they knew what it was, and then when it returned positive for breast cancer, positive margins, they started calling it an incisional biopsy, but she did have some lymph nodes that came out with that specimen as well, and so I think she had already had some lymph nodes removed. So.
Great question. Thank you, Dr. Zavar. Dr. Sugar?
Right, so with the lymph nodes, like Dr. Armstrong said, she had already had some removed at her initial surgery, and then following the adjuvant, they can also have some fibrosis of the lymph nodes. So total, there were 9 lymph nodes out, and I believe 3 of them were positive. With regard to the ovarian cancer question, so in this particular patient, excellent question as far as overall prophylaxis in the future, but for the patient who has a known diagnosis of breast cancer, we would treat the breast cancer first, and then when she's recovered from that, we can refer her to the OBGYN to discuss the prophylactic ovarian.
Very interesting. It's interesting that regional lymph node dissection, whether it's for melanoma, for colon cancer, for lung cancer, each specific society in the American Cancer Society have come up with a nominal amount of lymph nodes that we're supposed to get. As a matter of fact, if you try to bill for a mediastinal lymphadenectomy and you've taken 9 lymph nodes out, you won't get reimbursed. And it's interesting to see that not only in the mesenteric circulation, but also in the cutaneous and the thoracic too. I think head and neck, there's some nominal amount of lymph nodes also that need to be taken during oropharyngeal cancers. Very nice presentation. Thank you. All right, any other comments or questions before we move on? Okay, thank you. I would like to say that we couldn't do any of this without several people that we work with every day, and I think sometimes we take these people for granted. Stacy, Jenny, and Debbie, Tammy, and Wendy, we don't know what we'd do without you. I come here, as a new chairman and not knowing a lot of things, and I must say Stacy treats me like her son, even though I'm much older than her. And that's the way it should be. Also, I'd like to state that if you can help support this event, several have already donated to the John C. McDonald Surgical Society to help Dr. McDonald's long-term goal of surgical education, and also the Surgical Resident Education Fund. There's also a fund for the Abramson Fund, which helps the residents also. A lot of these can be done online, and we certainly would appreciate any monetary event that you could help us with. Second case, Dr. Castile and Dr. Chu, recurrent ovarian cancer with obstruction, pelvic exoneration. I found this to be one of the best cases that we presented this year that we don't see a lot of in general surgery. Dr. Castile. Get your mic here.
Good morning. Thank you for allowing me to present. I'm Katrina Castile. I'm one of the 4th-year residents here at Austin LSU Shreveport, and I have the distinct pleasure of presenting a case done by our surgical oncology staff, Dr. Chu, and one of our graduating 5th years, Dr. Cox, a pelvic exoneration for recurrent ovarian cancer. So our patient is a 64-year-old white female. with a history of ovarian carcinoma who had undergone resection at an outside hospital back in 2013. She also had small bilateral pulmonary metastatic disease, which had been known since 2018. She was currently on palliative chemotherapy, and she was admitted at an outside hospital for a large bowel obstruction and also hydroureter on the right side. At the outside hospital prior to transfer, she got a right ureteral stent. When she got here, the CT of the abdomen and pelvis showed local pelvic recurrence and with involvement of the anterior rectum and the posterior dome of the bladder. Her past medical history was just mostly unremarkable, just for hypertension, osteoarthritis, and hyperlipidemia. Her past surgical history, she had undergone a total hysterectomy with salpingo-oophorectomy. Upon presentation to our facility on physical examination, her abdomen was slightly distended, however, otherwise unremarkable. Her hemoglobin was stable, no white count. Her vital signs were stable. She was also afebrile with a creatinine of 1.1. After speaking with the patient in general, we decided to take her back to the operating room. Here is her CT scan, which showed a hydroureter with the stent that had been placed at the outside facility. Also, the right side of the colon with significant stool burden as a sequela of her obstruction, as well as going further down the pelvis with her local recurrence involving the bladder, the rectum, and actually the superior cuff of the vagina as well. So we decided to perform an pelvic exenteration due to the location of the recurrent tumor at the superior cuff of the vagina and the anterior portion of the rectum. We made a midline incision where we saw the mass that had involved the rectosigmoid, the dome of the bladder to the trigone. It also had involved the distal ureters bilaterally and the apex of the vaginal cuff. We mobilized the sigmoid and rectal colon without issue, with the lateral planes looked like they did not have any involvement and no pelvic sidewall involvement at that time. There was a small short segment of the ileum that was involved, and we resected about 5 centimeters and took that and blocked with our specimen. Urology was consulted intraoperatively, where they came and evaluated the involvement of the distal ureters, where they were transected, and a cystectomy was also completed as well. We also did a partial vaginectomy, and we completed the LAR with a primary end-to-end anastomosis, with also a diverting loop ileostomy and an ileoconduit. Post-operatively, she did well. We admitted her to the ICU. She started on clear liquid diet, and she was able to advance her diet without difficulty. She received proper ileostomy and urostomy care, and she was actually discharged home on post-op day 5 with home health help. On post-op day 7, she came back to the ED complaining of fever. The wounds were evaluated and they were healing well. We saw that she did have a UTI, and she was given 7 days of PO antibiotics. On post-op day 13, she was seen in a surgical oncology clinic, doing well, and now, right now we're still in the process of evaluating her for reversing her loop ileostomy. And this is the specimen that they took out, including the rectosigmoid colon. It's dilated here, and also the tumor that involved part of the vagina, the ureters. It's a different view of it. Is this the pointer?
Need a microphone?
No, so this is the part of the small bowel that came in. This is the sigmoid, and then this is the bladder all stuck in this area. And we had opened the bladder, and it involved the entire trigone of that area, and so they weren't going to be overloaded resect.
So her final pathology from the bladder and the vaginal vault, rectosigmoid colon, it was metastatic, poorly differentiated carcinoma. All resection margins were negative of tumor, and she had 1 out of 21 lymph nodes were positive. There was a focal ulceration within the small segment of the ileum that we resected, also positive for carcinoma, with their margins also negative. However, the colonic donuts, where we did our anastomosis, were negative for malignancy. So a pelvic exoneration is a procedure commonly performed for recurrent, sometimes ovarian, but mostly cervical cancer that involves removing the rectum, the bladder, resecting the distal ureters if they are involved on the medial aspect, and also creating a diverting urostomy, sometimes an encholostomy, sometimes if it's a proximal portion of the rectum, the patient can be reattached and they can do a loop ileostomy in order to divert the patient temporarily. A lot of times these patients have also had their uterus already excised due to the first portion of their treatment. And so usually the uterus is not resected at that time, it's already gone, but sometimes a vaginectomy is performed. The 5-year mean survival is about 50%. However, this is variable for the primary tumors and also whether or not this is just for palliation, as in if the patient is obstructed, or in our case, no, she also had obstruction of the ureters as well. When it's for palliation, the median survival is approximately 14 months. In one study, they show the overall complication rate is 70%, with re-intervention rate was around 20%. The most cause for complications usually wound dehiscence or infection. These people are on palliative chemotherapy, they've undergone radiation, so there is poor wound healing, and nutrition needs to be optimized. Another very common side effect or complications also GI fistula as well. These are previously irradiated fields, and for our patient, since she had undergone radiation in the past, even though she was hooked back up, we did decide to do her loop ileostomy just for that reason.
All right, great. Thank you. Nice presentation. You don't see many of these. I saw 2 in training at Ellis Michelle State Cancer Center, where Dr. Larimore and I trained in the past in Columbia, Missouri. But nonetheless, an operation I still think there's indications for with advanced pelvic, recurrent pelvic cancers and other causes. Dr. Larimore.
Yeah, congratulations to Dr. Cox and Dr. Chu for a great case, a very big operation. Just a couple of notes I might say. I'm happy to hear you say exoneration rather than exoneration. Exoneration is to absolve from all blame. Exoneration is to remove. And I had so this operation is a big operation, but urinary or gastrointestinal obstruction is a very bad way to go at the end. And so not only can this achieve local regional control, which sometimes can translate into long-term survival. And then one historical note, I had the pleasure of meeting the guy who kind of developed this operation. His name was Eugene Bricker. And he actually still came to conference at WashU when he was 80 years old and would occasionally stand up and say things. But the story goes that there were some scissors called the Bricker scissors. They're these big, huge, curved scissors. And when Dr. Bricker, he developed this operation, I think in the 50s or 60s. I could be wrong about that. But the story goes that whenever Dr. Bricker would call for those Bricker scissors, anesthesia would start to scramble behind it because they knew it was coming out one way or the other. He was going to start chomping with those scissors. But things have come a long way, and I really enjoyed your presentation. It's a great case.
Great. Dr. Sabari.
I also want to congratulate you. I think this is a nice case presentation, and I'm glad that there are people like Quinn Chu's doing it, not me. My question to you, what is long-term survival prognosis of this lady, and why not do an ileostomy in the event if she does get local recurrences and cause obstruction? Who would want to be in that pelvis again?
Yes, sir. For her, since her lymph nodes were positive and this was for palliation, her long-term survival is honestly about 10 to 15%. It's gone down drastically, especially with the positive lymph nodes. I believe the rationale for giving her the loop ileostomy versus end is because the location of the recurrence of the tumor was so high, she had enough rectum that we could hook her up and give her some semblance of normality and just divert her at the time. I know she does have distal mets in the lungs, which should be a contraindication for pelvic exenteration, but this was for obstruction and palliation.
Can I answer that?
Sure.
So this lady had been on palliative chemotherapy for over 18 months and had been doing well.
talked to her primary oncologist, and he expected her to have a long-term overall survival within years and not months, even though she did have these 2 lung nodules. She was independent, she lived by herself, she completed all her ADLs, grocery shopping, lifting, yard work. I mean, she was just the person that, could have an overall survival in 5, years or more.
Sure.
And so we thought the best thing to do for her is to offer her the best chance at a normality.
Thank you for taking ownership in this case. I can tell you, psychologically and technically attached to this patient, and that's what it takes for good operations. In the day of minimally invasive surgery, small surgery, observation, non-operative therapy, I think these cases have a place. And they need to be done at places where you're there a lot. Dr. Chu is there a lot. He's in the pelvis a lot. He sees big tumors. This is what differentiates us, I think, from the surrounding areas where doctors that can do a simple right colon, maybe a simple a small bowel tumor, or a minimally advanced gallbladder cancer. Those patients who come here with recurrence. So Dr. Chu and others, just like you, see the worst of the worst, or I should say the best of the best. We get a chance at preventing local recurrence, maybe not offering lifelong cure, but several of these patients will develop a symbiosis with their cancer where there'll be small foci of cancer in the lungs and the pelvis, but they live 15 years. Keep hitting it with chemo or radiation. And these patients, that's all they ask for, is a better survival and a better way of doing simple things like going to the restroom, preventing soilage, preventing local recurrence. So, Dr. Chu, once again, we applaud you on this case. I'd like your comments.
Yeah, I was going to refer this case to Dr. Zabari to do robotically, but I think he was out of town. I entirely agree with Dr. Cox's assessment. The reason why we don't see too many of these, and we do get referred for these, is because we really have to select the patient well. Number one, we got to ask, this is a big operation. Can the patient tolerate it? Are we going to be able to help the patient? And are we aiming to cure or palliate? And if we're going to palliate, are there alternatives that we could offer beside the surgery? So these are, it's a whole litany of things that go through our mind before we select the patient. So, like Dr. Cox said, this lady was a very good candidate and, the good outcome, and very nice presentation.
Yeah. Any history on her recurrence or a lack thereof? Be interesting to see what her follow-up is. If not, I'm sure she's doing, huh? She is, okay, good enough, thank you. All right, good enough.
I do want to make one more comment. We talk about pelvic exoneration, and we have basically a diverting ileostomy for the urinary diversion. In select case like her, she would have been a good candidate where you can get that distal ileum where you hook up the uterus to ileum, and you hook it right into the bladder. That way to avoid an ostomy in her, because it's all palliation. We discussed it with the urologist, and they were hesitant about it. But just keep in mind that there are places that it is possible in select patient that you don't have to give them an ostomy, that you can hook it up to a loop of distal ileum and hook that ileum to the bladder. And therefore now the patient doesn't have. Just something to keep in mind.
Dr. Sugarbaker, Dr. Bricker, of that lineage, no doubt, offered a lot with these advanced major tumors, especially at WashU and at Ellis Michelle. Any other comments about the Bricker loop?
Well, Dr. Bricker also developed that ileal conduit, I think is the way they would refer to it back then too. He was an amazing fellow. And, you have to think about the time period in which he was doing these big operations and developing that operation. And he did it himself as a general surgeon. And the only thing I could tell you about Dr. Bricker is that whenever he would speak in conference, he would always stand and put his hands in front of him. And he usually only said about a sentence and a half. And then he would sit right back down. But you could tell when Dr. Bricker was going to say something that he was a man of few words, so it was going to mean something if he was going to say it. But it's also called the Bricker ileostomy loop.
Sure. So We stand on the shoulders of gentlemen like Dr. Bricker, Dr. Evarts Graham, and others. Thank you very much. Nice presentation. All right, we'll move forward with our third presentation, our clinical case presentations. Dr. Briones and Dr. Zabari, left adrenal aldosteronoma, resistant hypertension, robotic left adrenalectomy. I wanted to present this case early in the year. I'm so glad we get a chance to do it at the end during the graduation. Dr. Briones.
All right, thank you for allowing me to present. This is a case we did back in February over at Willis Knighton with Dr. Zabari. So our patient was a 59-year-old African-American male, had a history of a previous stroke, type 2 diabetes, hyperlipidemia, hyperparathyroidism, CKD, hypokalemia with resistant hypertension, and this incidentally found left adrenal nodule. Past surgical history and social history, not very exciting. He was on a couple of different blood pressure medications, including labetalol, nifedipine, valsartan, and was taking potassium chloride and spironolactone. On physical exam, he was hypertensive, about 162/81, heart rate 84, no palpable masses that we could feel on exam, 193 pounds, but he was a pretty tall guy, so not very obese. Labs, not very significant. He had been on the spironolactone, and so his potassium had kind of normalized, and he took potassium supplements. He was referred to us already after having this CTA that was done looking for renal artery stenosis, and they found no renal artery stenosis, but they found this left adrenal mass, which you can kind of see coming into view here. It was about 2 by I think 1 centimeters in size. And after this, he was sent off for IR to perform venous sampling. They were able to sample both left and right renal veins, and these aldosterone came back elevated. So he was then sent to Dr. Zabari for further evaluation. And we took him back for a robotic left adrenalectomy, did a varus needle access, placed our subcostal ports, took down our colon and splenic flexure, able to mobilize everything, then incised gerotous fascia, identified the left renal vein, and then from there traced back the adrenal vein, which is dissected and ligated, and the mass was then dissected off the superior pole of kidney. I have some nice pictures of a better case that was done actually that same day, much more impressive pictures, and some intra-op pictures that kind of better delineate a little bit of that anatomy that we were discussing.
Can you bring the mic a little closer where we can all hear?
Yes, sir. So these are this was his second adrenalectomy of the day, with a much bigger mass. So he started with a little one, I guess, just as a warm-up. This is after that adrenal vein was then ligated, and this was removed through an endocatch bag and a small Fenton steel incision in a young lady. If I can get this to work, we'll have a short little video.
This video is about 10 years old. I gave a talk at the surgical meeting, and I made a few minutes short presentation of video. As you see, the quality of images on light is not as good as what we have today.
Sure.
But in any event, there are several case presentations, and I guess you could ask questions to the audience while they run this video for
Well, I think I'd like to make a comment as the video goes. I don't want to take away from the video itself, but the importance of Willis Knighton in our surgical education. Back in the early 90s, even further back than that, Dr. Satig and I were talking about hepatic transplantation, kidney transplantation, when Dr. Ike Muslow and others couldn't financially support the program. It was taken outside to Willis Knight, and Jim Elrod is that?
I mean, it runs on for 5
Does it run
minutes
up?
if you want to see, but that was...
Sure, let it run. I want to just comment a few things about that. When we talk about corporate versus educational needs for our community, we're in the midst of new joint ventures with other entities, but we can't forget who brought us to the table, and that was been Willis Knight and Jim Elrod. Huge role in my education, a huge role in my surgical success as a young faculty for cardiac transplantation. So while we're in the midst of changes in joint venture, the original joint venture was by John McDonald and Jim Elrod, and it continues to this day, not only for me as a cardiac surgeon, but for your education. So I try to, that's fluff. I try to look the other way when they discuss about that. So Dr. Zabari has continued his undaunting endeavor of transplantation and advanced hepatobiliary tumor, and along with Dr. Altman and in endocrine surgery. So once again, don't let the C-suite change your thoughts about what's brought us to the table and how it's been such a huge advancement in Shreveport and the advancement of surgical care in Shreveport. I'm still friends with Jim Elrod. I'm friends with Warner Thomas. So there's no doubt you can live in both worlds as long as we have good patient care and we have good surgical education for you guys. So I'll stop my bandwagon on that. Please proceed.
So our patient did great. I mean, post-op day 0, he was started on a clear liquid diet, tolerated that well. He was up and ambulating. Pain was very minimal and well controlled on just a little bit of oral pain medication. And he was sent home on post-op day 2. Just a little quick slide about kind of the workup with these adrenalomas. So you always want to start with a good, obviously, history and physical exam. The biggest differentiation is kind of if they're functional versus non-functional. So you'd evaluate that with different studies, including plasminonephrin, cortisol tests, and aldosterone. If they're functional, pretty much that's recommending adrenalectomy. If they're non-functional, you can just base that then on further studies, including imaging. So less than 4 centimeters with benign characteristics, you can typically just do surveillance with repeated imaging and biochemical tests. This in-between category of greater than 4 but less than 6, you look a little bit more closely at your house field units and your appearance, further appearance on radiologic imaging. And from there, you can decide whether they'll be candidates for adrenalectomy or surveillance. Greater than 6, typically, with house field units greater than 10 less than 10, straight to adrenalectomy. Our patient came back with pathology of, benign adenoma, so that was good. The other reason to take it out in these functional adrenalomas is they can have hidden pheochromocytomas. So that was another push to take this out in this patient. But he did well, so it was a good case.
Thank you very much. Nice presentation. Don't run off. We may have questions. Here you go. All right. Just a little comment about incidentalomas. With the advent of CT scanning the last 30 to 40 years, these tumors, which usually presented with metabolic derangements in large masses, have been now pared down to incidentally found tumors that can be taken out minimally invasive. So, Dr. Larimore, comment?
Yeah, I don't want to usurp all the microphone time here, but this is an interest I have. I just want to congratulate the residents and Dr. Zabari on 2 great cases. He obviously has a lot to offer with his expertise in advanced minimally invasive techniques and training. And I just want to make the comment, you mentioned that there was a very small tumor to start with and then a much more impressive one. Those tiny tumors can cause very significant biochemical derangements, and it's always impressive to me how a 1 centimeter adrenal tumor can cause such havoc with blood pressure and potassium in these people, and it can be fixed. The only other comment to make is that when I was training, if a patient had clear biochemical evidence of hyperaldosteronism, primary hyperaldosteronism, that is an elevated aldosterone and suppressed plasma renin, and they had a unilateral adenoma on CT with a pristinely normal contralateral gland, that was good enough. You could just take out but I applaud you for performing venous sampling in this patient. Increasingly, we're recognizing that probably almost all patients should undergo venous sampling first. You can have bilateral hyperplasia, which is not treated surgically. Sometimes they have asymmetrical nodular enlargement, and it can appear that they have a single adenoma. Dr. Bill Young from the Mayo Clinic has published widely on this, and the current recommendations, there are some people under 35 if they have very severe hyperaldosteronism that may not need venous sampling, but essentially everyone should probably undergo venous sampling. Great case.
Yes, Dr. Altman?
Actress, you had mentioned that the patient had hyperparathyroidism. What was the story with that, and anything done with that? Or?
So in my reading, it looks like from the hyperaldosteronism, they can get increased like dumping of the calcium, and so that'll drive up their hyperparathyroid function. It's in response to kind of some of this.
And for the residents, just remember too that you have to think about the MEN syndromes, and remember that while there is a set pattern to say that MEN1 has this, MEN2 has this, that it can be different variables of that. It's not always have to be a pheochromocytoma. That's the standard, but not always the case. So I think it's important to consider those when you're looking at these.
Donnie, keep the mic for a second. I'd like your thoughts. You're like me. You've been here for 4 decades, and have seen the translational change in medicine from the gown versus the town, that we're the academics and we're freestanding. Just tell the crowd and the people on the YouTube live that we have right now your thoughts about kind of the evolution of how surgery has been helped by Willis-Knighton and things like that, and how Ochsner is going to expand our bounds and the ability to recruit and make new things that we could not have done autonomously at LSU.
Well, I was a third-year resident in 1989 when this venture was begun with Willis-Knighton, and I remember Dr. McDonald talking about it before it happened, and I said, this ain't going to ever happen. I mean, LSU's not going to team up with a private institution. I think they're just talking and such. But it did happen, and I think that if it had not happened, many of the things that we have been able to see to fruition today would not have happened. Clearly, Dr. McDonald knew, Dr. Muslow knew that the state and the institution could not support liver transplant, heart transplant, pancreas transplant, and I think he did that, Dr. McDonald did that with Mr. Elrod, in order to see those things come to fruition. If it didn't, it wouldn't have happened. Willis-Knighton took a huge financial hit on the front end to begin those programs. It's been now beneficial for them in the future, but on the front end, they were willing to take hits because they could look into the future and see. And I think, a lot of these things, with Dr. Zabari doing the minimally advanced surgery, we started doing laparoscopic living donors in 1995. A lot of those things, we may not have been able to do if we did not have that joint venture. And so I think that the benefits that the residents have gotten out of all of these programs over the years is just astronomical. And, I think hopefully with Ochsner pairing up and teaming up, that some of those things will be brought to the university setting that may have been lacking or missing or not be able to be funded for many years. So hopefully we'll see that improve.
Thank you, Donnie. I'd like to comment on that one last bit before we talk about the corporate world and the academic world. And I'll expound on that a little bit during my talk later this morning. But, and I think Dr. Johnson in Monroe will agree with me that we want the best education for you. We want the patients. We want financial integrity, but we want the best patients that we can give to you guys to train you as good surgeons. So, as Willis-Knighton has come along, as Ochsner's come along, you'll see that in your fellowships and when you go out to practice, how the corporate world and the academic world can coexist. They can live together. As a matter of fact, they have to live together in today's environment. If they do not, neither one of them will be able to take care of what's needed, perpetuation of our education and perpetuation of good patient care, because we do things in this city. We do it at LSU, trauma, advanced surgical oncology, advanced endovascular, that nobody else does. So without us, I think we all need to work together, and we don't talk about names, we talk about education and patient care and we will use any way possible to get to the ends to that means. Dr. Johnson, you got any comments on that? You've seen a lot go on with the corporate world and the education and LSU over the last 4 or 5 decades. Love your comments.
Is it live? Can you hear me,
Yes, sir.
Dr. White?
Yes, sir.
Yeah, this has been an interesting journey for me over almost 50 years now, trying to overcome the encumbrance of the phrase town versus gown, or vice versa, in American surgery. It's a very unfortunate situation that somehow we came upon in the 20th century. Back in 1980, when I was in private practice in northeastern Louisiana, Dr. Sion and I, we had surgery residents, 2 surgery residents assigned to us by Dr. McDonald for probably 5 or 6 years at all times. It was a wonderful experience for them and for us as well. But the powers that be, the geniuses in Chicago, New York, San Francisco, wherever, decided that that, of course, was not a good model. And the side effect of that, of course, was to deny the residents the opportunity to go to the places where the great cases were. Now, over time, that can't be allowed to stand. We fought that for the last 25 years that I've been here in every committee at the American College of Surgeons, the American Board of Surgery, the residency review committees, the educational committees that need to oversee the training of the folks that teach resident surgery. All of that's good, but they still, Dr. White, have to have the surgical experiences in an operating theater with trained great surgeons so that they can learn from this during their residency. There's no reason in the world, as evidenced by what you say with the Willis-Knighton experience, the Ochsner experience, and so forth, that we can, in a measured and reasonable way, work together to allow the residents and the fellows to have more surgical experience during their time with us, to restrict them to only the university hospitals at Monroe and Shreveport and perhaps the VA is not a good idea. It's not good for them. It's not good for anybody, and anybody that's afraid of that is just needs to have an adjustment of some sort. So I've made this speech a lot. Thank you for giving me this opportunity this morning. It's not over because there's still restrictions. And we'll continue to fight this as we go forward because the number of, it boils down. We've had this so many times with Dr. Zabari, Dr. White, Donnie. The number of great index cases that you have during your residency is just so indicative as to what sort of surgeon you're going to be for the first 5 to 10 years of your practice, and it's surely not okay. And of course, you're going to have mentoring after you leave the university from your colleagues in a collegial fashion, not a competitive model, hopefully, wherever it is that you are, so that you get help and advice and have good consultative opportunities with your fellow surgeons. But there's nothing like the experience during the residency itself. And we need to expand in every way that we can, good opportunities for kids to have an increased number of cases. But I can tell you that's not the philosophy throughout the nation. We'll have to take it on, try to be reasonable and measured, and try to overcome some of the backward thinking. That's my opinion.
Thank you, Dr. Johnson. Always. I appreciate you. Dr. Zabari, you want to finish up with any last comments on the case or anything else you'd like to discuss about our relationships?
Well, clearly, we all were here when all of this started. And again, we did not really want to go across the street, but McDonald, Maslow, and those guys were visionary. They knew that we could not sustain. In fact, Even after we moved the adult transplantation over there, we kept the pediatric over here. We had a very successful both kidney and liver transplantation. Unfortunately, they did not invest in it. I got salaries for our nephrologists, ped nephrology and hepatology. The money was given to everyone else except those guys. So they ended up leaving, and the program was shut down. So we did not have the necessary support, and I know a lot of people put finger on us that we doing that work over there, but it was really necessary. And the old academia, I do believe that has ceased to exist. I do believe that there has to be a collaboration between both academic institution and private sector, and that's where both patient and residents would get the best out of it. And I congratulate you for actually promoting minimal invasive surgery. I think the surgeon you train now, they have no option but to get well trained in minimal invasive surgery, and I think that department doing a very good job. I do believe when these guys leave, they are well trained, and they could compete with anybody, anywhere in this country and worldwide. So we are very proud of them, and thank you for your leadership.
Thank you so much, Dr. Tabari. Hate to get off on the geopolitical aspects of medicine, but I think you're going to find that proline, Vicryl, and Ethibond, it's not all about that. It's all about how we live together, how we train together, and how we can do better for our patients. And in the end, y'all get a great training. I work with Intermountain Healthcare when I went to Utah. It's the first, I'd worked with here at LSU. Never really had any private entities when I did my general surgery training. When I got over there, I saw how well it could mesh and work. John Luke will be, and all of you will be working with private and industry, in addition to, the academic setting. So don't forget that. It's funny how so many surgeons were trained in Shreveport at this institution, and occasionally not the nicest things come out of their mouth when they have trained here decades ago and got a great training. So we can't forget where we started, because it'll always mean a lot to you those first few years of training. Thanks again, Dr. Johnson, for the comments. We'll take a short break. In 15 minutes till, we'll start with our research. Thank you.
I will take your case ballots if you have them.
Yes.
Just hold them up and I'll come to you.
Use what? Oh, God,
Okay, that is fine.
go.
Other cases?
Yes, cases.
Yes, yes, thank you.
You're welcome.
Okay. Good, good, okay. One time in part of the year, huh?
Dr. White, would you like to be in this picture with the
I would love to.
research? I'm gonna turn on a little bit of light. Just a little bit.
Go back down.
Yeah, I will. Just for the,
Used to be.
yeah, how about right here against this wall? That'd be good. Okay, babe.
Hold on.
I'll get the pictures.
You probably said, "Oh God, I won that. I got to present again."
No.
But you know, you're doing it live now, so it's different.
Okay, scoot in just a little bit. Okay, 1, 2, 3. Okay, one more. 1, 2, 3. Very good. Hang on just a second. Dr. Castile? Oh wait, where's Armstrong? Okay, I'm done. Yeah, I'll get you in just a minute. I'm gonna take the case presentations as well. Put on the website.
Sounds good.
No drama yet. No, we're good.
Oh, wow.
Yeah, did you see the resume? Yeah, that was good. I mean, mine's not gonna show you.
You know, I think I replied to you that I did reply to you that isn't live because and I did reply to you about when you texted me.
Or,
No, I had no.
I tell you what, if you move back this, I don't know if it's there, and that way I'll wait for him to sit right there. Okay, I'll wait.
I want to waste his time, but I will go back and hopefully July when these will be
July 6th.
Thank you, I appreciate you.
Clinic stuff, and I can do that.
And then, what does he need to do? Does he need to come in?
You know, just like whoever the resident surgery. Well, we'll find out. But whoever's they can. I just can't do that pre-op start here. No, that's fine.
Okay, so who you show up and then?
Yeah. Okay. Do that. Yeah. I'm just Mark and they're finishing up and they're supposed to head over. Mark had a case, Donald was going to round and come over.
Oh, good.
Be over.
We got plenty of room here. So.
Okay.
Yeah. Thank you. Appreciate you.
Feels different, right? You have an excitement for the evening, you know? Yeah. But now it's like all.
It still has a, I think like maybe like one certain thing kind of slows down. Get a chance to
Maybe when the pager is gone. I think when I drove to St. Louis from here, it was a good week. Kind of felt alone again. You have to see. I didn't know anybody over there. I got 2-3 phone calls to join the fellowship during my road trip to St. Louis. People are calling me, hey, that was interesting, you know? Actually, all the masks, you should have all that.
I'll have one with all the masks on. Remember, right, the COVID. Hey, over here, guys. We'll do it on the white wall. I wait for Dr. White to see yeah, over here. All right. Oh. Okay.
It is so ironic to have 3 female.
3. 1, 2.
Stop it.
Ironic. That's right.
the real world.
Maybe he's busy checking his emails.
I know. He's busy doing other report. He doesn't get enough sleep at night.
And then you're up.
No. So I actually. No. I moved Maria. And we drove. But then I flew back. Graduation event was also in it was quick, but it was more like a formal and then informal. They do it in a very nice way. Yeah, they're all like, to me, like, in India, junior residency in like I had then England comprehensive, like I had 2 extras. After that, it's busy. Oh, I know. Let's see. When I was died, let's see, that was 2000.
That's
Yeah.
when you met her?
Yeah.
You were her patient?
Yeah.
That's like not okay.
Okay, calm down. It was only after our discharge.
That's what all the nurses say when they go out with the patients. Oh, you want to make, I guess I should.
Well, of course, Dave Neal's not.
I can't like go back and look at
This trauma patient control, and she like went out with him. So it's a little uneven.
Yeah, I know. Okay, I'm not the child patient. You have it.
And at least I just can breathe.
All right, let's take our seats where we can stay on time today. Okay, everybody ready to get started and get going? Remember, we're on YouTube, so everyone's watching. So straighten your tie, act right. We'll start with the second portion of our graduation celebration. I would like to make a comment on some of our residents that have matched to other programs. Dr. Rob Willard, honored to say that he matched at Montefiore in New York in cardiothoracic surgery. And I think this is, congratulations, Rob. I just can't see Rob Willard in New York for some reason, but it's going to happen. And no, I'm just teasing, Rob. I think trained a few heart surgeons that were fairly good at LSU, and hopefully we'll continue in that line. First presentation, and these were voted on once again by Dr. Chu and myself, Dr. Larimore, and Dr. Samra. And we looked at this. We looked at the abstract. We looked at the style of presentation. We looked at the content. And the thing that is kind of stood out is that simple is good when it comes to presentations. The statistics are solid. The presentations showed vigor. They showed, even though we did do these presentations virtual through WebEx, today we'll get to do them live. So it's just a little bit different, although we've heard them. The caveats just somewhat different. So first case is Dr. Arrieta. Julian's going to talk about seeking treatment outside of health service area. It affects the rate of radiation therapy following lumpectomy for breast cancer. Julian?
Hello? Hello, can you hear me? All right. All right, well, let's see. All right, well, good morning. Thank you for allowing me to present. My name is Julian Arrieta. I'm one of the first-year surgery residents. So today I'll be discussing breast cancer patients seeking treatment outside of their health service area and its effect on their likelihood of completing or remitting radiation therapy following lumpectomy. I'd like to thank my mentors for this project, Dr. Larimore and Dr. Sugar, and also special thanks to the Department of Computer Science and Bioinformatics at LSUS for their huge contribution to this project. So I have no conflicts of interest to disclose. So there have been numerous studies showing that mastectomy and breast-conserving therapy, or BCT, are equivalent in survival in the treatment of early-stage breast cancer. Post-operative radiation therapy is integral in BCT to eradicate microscopic residual disease, to maximize local regional control, and overall survival following lumpectomy. So the differences in breast cancer treatment and outcomes due to geographic or socioeconomic variables is an increasingly recognized problem, and unfortunately. And although the use of BCT has increased during the past 20 years, several previous studies have demonstrated a relationship between distance from a radiation therapy center and breast cancer treatment and quality. For instance, increased travel time from radiation therapy centers as well as lower socioeconomic status are associated with decreased rates of completion of breast-conserving therapy. However, there is limited data that exists studying patients who seek treatment outside of their health service area, or HSA, and its effect on completing radiation therapy following lumpectomy. So a health service area is defined as one or more counties that are relatively self-contained with respect to hospital care. Service areas that include more than one county are characterized by travel time between the counties for routine hospital care, and shown here is just an example of the different health services in Louisiana. So The purpose of this study is to evaluate the effect a patient's decision to receive treatment outside of the health service area, or HSA, has on their likelihood of receiving or omitting radiation therapy following lumpectomy for breast cancer. And we also looked at the associated rates of local regional recurrence, as well as overall survival, using data from a large cancer outcomes database, which is the SEER database that we use for this study. And we also included all stage 0 to 3 breast cancer patients undergoing partial mastectomy from 2007 to 2016. So two groups were established based on proximity: patients living in a county code covered by their treatment center's HSA or inside HSA, and patients who live in a different county code outside of their treatment center's HSA or outside HSA. And so the rate of patients undergoing radiation therapy versus omitting radiation therapy following lumpectomy was then determined for each group, as well as the local regional recurrence and overall survival. And we used chi-squared analysis to determine significance. So there were about 260,000 patients in the SEER database with stage 0 to 3 breast cancer treated with partial mastectomy during that time period. And so for patients receiving treatment within their HSA, about 75% had lumpectomy with radiation therapy, and 25% did not have radiation therapy following lumpectomy. And for patients whose treatment is outside of their HSA, about 82% had lumpectomy with radiation therapy versus 18% who did not. And so patients receiving treatment outside of their health service area were statistically more likely to undergo radiation therapy following lumpectomy. And Table 2 is essentially a validation that patients undergoing radiation therapy following lumpectomy have improved overall survival compared to patients who omitted radiation therapy. Now, patients receiving treatment outside of their health service area had no significant difference in local regional recurrence compared to those treated within their HSA. However, patients receiving treatment outside of the HSA have improved overall survival compared to patients who received their treatment inside their HSA. Additionally, patients receiving treatment outside of the HSA were statistically more likely to have stage 2 and stage 3 breast cancer compared to those treated within their HSA. So the vast majority, about 98% of these patients receive their breast cancer treatment within their own health service area. However, 2% of patients are treated outside of their health service area. However, these patients are more likely to receive radiation following lumpectomy. And despite being more likely to have stage 2 to 3 breast cancer, they have an increased overall survival. So the SEER database that we used was originally intended to gather epidemiologic data and not really using disparities in treatment outcomes. And so some of the limitations of the SEER database is that there's no data on comorbidities, insurance, or individual level socioeconomic status, as well as some of the incompleteness of individual level data on specific cancer risk and treatment. So patients seeking care outside of their health service area likely represent a distinct subset of patients, breast cancer patients, possibly with increased ability to travel to regional and national treatment centers. Other possibilities can include higher socioeconomic status, and maybe these patients are more likely to be motivated to seek care outside of their own health service area, or maybe they're referred to other treatment centers from their physicians. But either way, more research is needed to determine why this phenomenon exists, and some of our future considerations for this study will include demographics such as age and race, median household income, insurance status, and also breast cancer data itself, such as the tumor size, nodal status, and receptor status as well. Okay, these are my references. Thank you again for allowing me to present.
Very surprised that this paper is not a publishable write-up, I'll be honest with you. This is just some good information that I think is needed. And it talks about outmigration. It doesn't tell you exactly everything and teases out all the nuances about socioeconomic level, why people go to MD Anderson, why people stay here, why do people in Baton Rouge
not be treated at Mary Bird Perkins, and while they may go to another referral area. So, comments on this case, Dr. Livermore?
Congratulations. I agree with what Dr. Klein said. I really think this is a very high-quality study, and Dr. Arrieta and Dr. Sugar have done a lot of work on it as well. Also want to recognize Wendy Chris. I just might point out that disparities in healthcare treatment and outcomes are a huge national concern right now. The NIH has designated disparities in cancer outcomes as a major fundable issue. And we recognize increasingly that patients are treated differently, and they do differently depending not only on their race, gender, socioeconomic status, but even their geography. And so closing the gaps of those disparities is one of the most important parts of cancer care right now, and a major impetus. And I think this adds to it greatly. I just want to congratulate you on a great study. I don't know if Dr. Chu would have a comment.
Dr. Chu's published most recently on disparities in healthcare with breast cancer, so his comments will be interesting.
I think this is a wonderful paper, and I congratulate Julianne and Dr. Sugar and all the other authors. I highly recommend that you continue this work and submit it to the annual ACS, Louisiana ACS competition. And if it gets voted to be one of the top 2, we then submit it to the national level. 2 or 3 years ago, we, in the whole state of Louisiana, we selected a paper from, I think, New Orleans, and that eventually won the national competition. So we in Louisiana have great capacity to do great things, and I think this is a very nice paper, very well organized, very provocative question, and I highly encourage you to continue to work this and then submit it to you for competition.
Thank you, Dr. Chu. If you could bring it over to Dr. Sugar, please. I must say that disparities in thoracic oncology I'm very interested in North Louisiana, because if you look at the third next available appointment and some of the times that these patients are seeing us after a pulmonary nodule or maybe a stage 1 cancer, statistically longer than other portions of the nation. And what is that? Is there access to care, decreased referral patterns, patient issues, socioeconomic levels? So I think there's so many things, not in just breast cancer, but in a lot of oncologic, entities that we see that are not being treated quickly in Louisiana. And this is going to be, with the new databases, this is going to be seen. It's going to be seen. It's going to be all over the United States, not just regionally. Dr. Sugar?
Yeah, so we were actually, when we first ran the numbers, we were very surprised to find this outcome as well, and so that's when we started really thinking about, well, what could be driving this? And so there are now some more data that we are planning to collect, the demographic information, refine it a little bit more, and then definitely proceed with getting this published.
Good enough. All right. You didn't know, Julian, if you didn't see which areas they were out migrating to, did you?
No, not specifically, sir.
That'll be interesting to see the origination area code and the destination to see exactly where they were treated. And that data is available. There's no doubt about that. So you might want to integrate that into your future papers on origination and the final destination as far as therapy and their zip codes. Nice job. Thank you for a nice presentation. We'll be voting on this one also, so. Not this one specifically, just the one that you think are the best of the 3. All right, next case, Dr. Briones gets to be front and center again. I think this is also a very nice paper, Healthcare Providers' Preference on Open versus Restricted Visiting Hours in the Surgical ICU. I am very interested in this because it shows disparities not in patients, but in our own healthcare providers.
All right, so healthcare provider preferences and ICU visitation hours. So I have nothing to disclose. A little bit of background. ICU patients experience various physiologic and emotional stressors when they're admitted with a decline in their health. They're also in an unfamiliar environment. All this can kind of contribute to delirium and hinder their healing. There's been a recent shift to allow more flexible ICU visitation hours, which would increase time with their loved ones and hopefully improve sensorium and mood. This, in theory, could also facilitate healing and communication between patients, family, and healthcare providers. However, this has the potential to interfere with the healthcare that's provided due to just the physical barrier of having more people present, as well as the emotional toll on healthcare workers from increased questioning and concerns from their loved ones. There's been some studies that have focused on medical ICUs or just ICUs in general, but there's not much information specifically looking at surgical or trauma ICUs, which are unique in the conditions that they house. So therefore, we thought it important to evaluate the aspect of this potential change in our own surgical trauma ICU. So our objective with this study was to investigate how restricted versus unrestricted hours could impact providers in a surgical and trauma ICU. This is a single institution IRB approved survey study where we gave out a Likert scale survey. This was distributed to healthcare providers that worked in a surgical ICU, our surgical ICU, excuse me, and they were asked a series of questions on preferences and perceptions regarding open and restricted hours. Their responses were then pooled based on descriptive statistics. And I do have, I'm sorry for these busy slides that follow, but I did want to include all the different questions that were asked. There was a total of 14 different questions. In summation, they asked whether open ICU hours are better for patient-centered care, if they increased stress on healthcare team, families, and patients, caused interruption in workflow, contributed to increased workout, or if they improved communication. And then the following set were looking at whether restricted versus open hours would provide patient privacy, if this would make them feel isolated as patients, if it would decrease the stress on staff, increase communication barriers, and ease performing procedures and promote better healing. So sorry about that. Our results, we had a total of 93 respondents, including respiratory therapists, speech-language therapists, nurse practitioners, occupational therapists, and resident physicians. The majority of them were our nurses, and residents were about a quarter of that. A majority of them had about 5 years or less of experience working in the surgical ICU, while only 14% of them had about greater than 15%. And as you can see, over 80% agreed or strongly disagreed that open visitation would provide better patient-centered care. The majority also agreed or strongly agreed that open visitation would increase provider and patient stress and provider burnout. However, they strongly agreed that open hours would cause better healing for the patient. And only about half disagreed or strongly disagreed that they would lead to increased communication barriers. So with all this information in mind, we pooled our results. We ran a one-way ANOVA using a score from 0 to 4, with 0 being strongly disagree, 4 being strongly agree, and then compared between professions to see if there was any statistically significant differences. And I chose to focus on just a couple of those questions because, as you can see, we would have, tons of these results. But looking at relieving familial stress, nurses, there was a significant difference where nurses, in comparison to all the other groups, thought open ICU hours would relieve familial stress. Looking at reducing healthcare provider stress, there were no significant differences between all groups. And then looking at improving communication, again, nurses, who are the ones that spend, the most time in these ICUs, agreed that it would improve communication if we moved forward with these hours. So overall, our study shows that perceptions are negative towards open ICU hours due to the increased stress and burnout that this can have on healthcare providers. I think this shows that there needs to be just further education for providers, as there's been other studies that do show there's decreased delirium and improved outcomes in our patients. There's been different studies. There was one large one in JAMA that it was done in Brazil, and they had previously had a randomized controlled trial that actually showed no difference. However, their meta-analysis showed that there was improvement. So I think we have to continue to kind of research this area moving forward, we'd like to do a repeat study if and when Ochsner converts to open ICU hours. And so that would be the next step here.
Good. Thank you very much. I guess another interesting aspect could be is to look at the COVID era of the last month or so, see how it compares where there was virtually no visitation, and see actually what the healthcare outcomes were if you could match the appropriate pathology, operation, and post-operative management. So very interesting. It's funny that in your study, that the nurses know this would help get better, but they didn't like it. So one of the slides showed that they thought it would have better healing. I was interested in a QI study very similar to this that would entail telephone use, cell phone use, and not across just nurses, but across all healthcare physicians, and how it could be deleterious to healthcare. As a matter of fact, Intuitive, when I went to their mother lode in California and looked at how when they built the actual robots, that they said the one biggest thing for increased efficiency, less mistakes, and outcomes with what they felt was robotic production was cell phone use. It's the big pink elephant in the room. We can't live without them, or can we? Can the patients live without them, or can they? You know, we have so much information that we use, but how often is that vital information that helps with patient care? So what kind of questions do we have? This is a great study also. Dr. Chu, or excuse me, Dr. Miri.
Yeah, this is excellent and important study. And the provider's response were subjective. And I think it should not matter. It should be based on something important, and the most important is the patient's result. If the patient's result is better, we have to change the culture. We want to have a big saying and autonomy in what we do, and it may be wrong. The subjective thing should be taken out, and when they say that they don't agree, we should say why you disagree and why you agree, and then it makes the things more reliable. It's a very important subject.
I'm just curious, with 49 nurses, if you can differentiate day shift from night shift, because the culture of the personalities of when they work, and my bias is that the nighttime nurses work that shift because they don't want to deal with families.
Yeah.
So if you start to query them on whether or not that would be a good thing to do, I would venture to say that they would be the ones that would be not very supportive of it.
Now, if you look at, you talk to administration, it's a big, they push this at every level. And they say, well, the pediatric patients are better served with families there, and they always have been. They try to extrapolate that to adults. I'm not sure if you can compare those data, to be honest with you.
Thank you for your for comments. Dr. Satiq's question, we do have that data, and I can get back to you. The most on this one, it was an equal balance actually. Both, I would say, half and half, night and day. There was a lot of enthusiasm from the ICU nursing staff about this study. I do want to mention, which I would say what Dr. Sorrell's thinks about it. So in trauma ICU population patient we have, if there is a mechanism of injury because of, if there's a gunshot or it's like a assault case, it's a very stressful environment for the nursing staff taking care of that patient in the trauma ICU, adult. But in peds, I have seen the opposite trend. I've seen more nurturing and more involvement with the family members, and actually the healing process has been better for the pediatric ICU patient population. I haven't done the study in that yet because when I started doing this, I thought I'll start with the adult first, then I'll move to the peds. But just I wanted to make a comment on that.
It's a great comment. Dr. Weigel? I think every one of you will be going to hospitals that'll have unrestricted, post-COVID, to have an unrestricted visitation policy.
Thank you. I don't think there's any question that patient care improves with the patient's family there. It's been well shown that this helps prevent delirium, which is one of the major issues in the ICU. The thing you have to look at, however, is the actual structure of the ICU. And I would submit that this ICU that we have here, which is outdated by about 40 years, is not structurally fitted to constant family interaction.
Couldn't agree with you more. That's going to change July 1. I don't know if any of you have been on the 4th floor where our new ICUs are going to be. All private rooms. Can't tell you, it's a shift. Dr. Zabari, did you have any comments? Okay. I'd like to ask Dr. Alley and the people at Conway how they think that that's acceptable as far as the Conway experience with patient visitation.
Good morning. What was the question, Dr. White?
Yeah, I just wonder if y'all had a feel, if you had a feel for visitation over there. Is it unrestricted now, or, you know, pre-COVID, what was the standard over there?
Pre-COVID, I don't believe it was. And currently, there's a strict COVID visitor policy.
I retract that question. You look tired. Yes.
Sorry, I haven't. Yeah.
There's always been hours for the ICU as far as, like, I think there's been 2 times in the morning for an hour that they can come and 2 times in the afternoon. But now with the COVID, they're now just not allowing 1 visitor to come back finally.
Dr. Sorrells, you mind commenting on the pediatric, what you think? You've been on both sides of the block, and how you think unrestricted visitation is good or bad?
I think it's one of those trends that is something we can't avoid. I think that in hospitals competing with other hospitals and families wanting to visit their loved ones, wanting to be there when their loved ones are critically ill, I think hospitals are kind of forced to accommodate that. With kids, I think it's a little bit obviously different than adults. For children, we encourage it, and usually the moms or the dads will stay with the child as much as they possibly can. And I think it helps, obviously, the child sort of feel at ease. But I think this trend, I think the more that a hospital can allow a loved one to be there, the more appealing that hospital will be. And so
exactly. I agree with the trend nature. When you're looking at things, what are the endpoints? Patient satisfaction. They're looking for better patient satisfaction because it helps them build better reimbursement, better referral base. So, but when you have to push a box and check a box, you have to ask the question, why are we doing this? We also were checking boxes on pain control 10 years ago. Everybody had to be a 0. Everybody had to be a 3 or a 4. And where did that lead to us? Hopefully we won't see in the long term with longitudinal studies, is an increase in infection rate? Is the burnout worse? Things like that. So we have to look not only at the patient, but also the providers. How is that going to affect?
I have just 2 kind of questions. Maybe one thing would be interesting is to talk to the floor nurses, because they have, it's not a new thing for them to have full-time, equal or full access patient visitation. So I'd be curious to hear if they have different perceptions about it, and maybe that could be used to alleviate anxieties on if there is the transition with the ICU nurses, because the floor nurses deal with the same families just a few days later. But I also think that this is very timely with the introduction of the rights of patient caregivers that Ochsner released and published maybe 6 or 8 months ago. Because historically, nurses, respiratory therapists, doctors felt that if there was a disgruntled family member, our role was to be a punching bag if needed. But Ochsner really delineated, no, you should expect to be treated professionally, and no vulgar language, and no abuse of the staff. And so I think with this both simultaneously occurring, the patient caregiver rights along with equal access to visitation, it might alleviate a lot of anxieties.
I totally agree. I think we're going to find a happy medium somewhere. I think we've been to both extremes. We've definitely been to both extremes with COVID versus pre-COVID, and see where we stand. Can't help but believe that it's good for patients that are elderly who need orientation. Not so sure about 6 family members and a trauma patient that are huddled around the bed that could potentially hurt the access to the patient themselves.
I agree with that, and that's a really valid point. When you have the entire church clustered around the bed, I mean, you just can't get anything done.
Couldn't agree with you.
And there needs to be restrictions on how many people and who can be there. And
I think the competition between the hospital, whoever said it, that's a very important point, that we're all fighting for the best patient satisfactions. And those satisfactions levels are, you have to be in the 95th and above on patient satisfaction to get to the bottom 25 percentile. So we're fighting that. And I think it's much more for physician engagement, that the physicians need to be present with some of these discussions with the families. Poor nurses have a lot of pressure on them now. Transmit information, take care of patients, make sure they're happy, and make sure that they're safe. So, Dr. Aziz.
So, with the modern medicine, with the hospitals sort of competing with the highest patient, with the highest sort of insurance, which is going to pay the best, healthcare is a hospitality industry. It's like if you go out all the big hospitals, I can name them, you go out to Cleveland Clinic, you go out to Mayo Clinic, you go out to Ochsner in New Orleans, any one of the bigger hospitals that publish hundreds and hundreds of papers of high volume and everything and cutting edge stuff, all of them, you enter their atrium or enter their lobby, I'm sure it's going to look better than Bellagio's. So these things, anything as a hospital administration will look into doing anything which is going to improve satisfaction. Now, and that's probably one of the things why most of the bigger hospitals have separated trauma ICUs from CT ICUs, from transplant ICUs to neuro ICUs, because the family demand and the patient demand, first you have to provide them with specialized nursing. That's one part of it. Your outcome is better if you have a specialized ICU for everything because of the specialized nursing care. But at the same time, you can cater to the families better. In my opinion, if you have a family member by the bedside, it's actually good for the physician. Do not take it as if you go out there and work in a private hospital, do not take it as a hindrance, because it's very easy to explain to a patient that your loved one had an open aneurysm and now they're on a vent. That machine is breathing for them, that machine is doing dialysis for them, that machine is doing this for them, and they can look at the monitor. They're very educated, they're reading. Especially if you are sort of in the market to cater to the patient who are going to bring the most amount of financial resources to your hospital. And we talked about that in the morning, as Dr. White was saying. These patients are necessary to do cutting-edge stuff. You are not going to be able to provide cutting-edge liver or heart or kidney transplant if you are only seeing patients who are not going to, whose insurance or Medicaid is not going to pay well. You need to attract these patients, and unfortunately, this has become a hospitality. I should say, unfortunately, the reality is it has become a hospitality industry. You have to build a 5-star hotel to get the patient come in, because to tell you the truth, most of us, for our own health care, would want to go to a waiting area which is nice, which is clean, waiting time is less, go to the emergency room where you do not have to wait 7 hours or 6 hours. It's just the reality of it.
No doubt. Patient access is so important. In aesthetics, parking, safe transit to the hospital, the things that make it easy. You're sick, and you don't want to have to worry about some little nuances about waiting 6 hours, like Dr. Aziz said. So I think there's a lot of things that we can improve on. I think Ochsner is built into that. They know that, Linwood and Kings Highway, as you'll see during my talk, has been equated to trauma, indigent, a charity care. So to try to drive a different patient population here is going to be difficult at all manners. And Willis Knighton understands that. The Greenwood Road, when they opened up Piermont, everyone wanted to go to Piermont because it was so nice, so accessible, so easy. But we could write a whole other paper on how we could do that here. Very nice. Thanks again. Last presentation, which I really liked also. Dr. Kate Rhymes is going to talk about overutilization of chest x-rays in the trauma ICU. Very simple paper, but I think very good and well-timed.
Can everyone hear me?
Yeah.
So So my presentation is on the overutilization of chest x-rays in trauma ICU patients. I want to thank Dr. Sammer for being my mentor. Special thanks to Dr. Larimore, Wendy Chris, Zach Connolly, and Tia Range, who just graduated from medical school, for help with this project. I have nothing to disclose. A little bit of background: chest x-rays are one of the most common radiologic studies ordered in the trauma ICU. The average cost of a chest x-ray, which we don't usually think about, is $200 to $400. And prior studies have shown that the diagnostic and therapeutic value of routine daily chest x-rays is low, and eliminating daily chest x-rays does not adversely affect patient safety. The purpose of this study is to examine the utilization of routine chest x-rays in the trauma ICU patients at a single institution. So taking a look at our ordering practices. Our hypothesis is that unrestricted daily chest x-ray ordering practices result in an increased number of chest x-rays performed without clinical indication. Our methods: this is a retrospective chart review approved by the IRB. It's on trauma ICU patients who were admitted for at least 10 days in the ICU and at some point were intubated. Our chest x-ray orders were categorized between indication-based versus routine. An example of this indication-based would be post-procedure, after an intubation, a central line placement, bronchoscopy, or a chest tube placement, as well as for a clinical workup of a new clinical finding: new fever, new shortness of breath, tachypnea, or concern for aspiration. Our patient characteristics: we had 70 patients collected. We had an overwhelmingly male population in this trauma, as well as blunt as the injury mechanism, and our average age was about 53 years old. Getting down to the chest x-rays and examining them, we had 1,587 chest x-rays that I looked through to determine, based on the order, whether they were routine chest x-rays versus indication-based chest x-rays. So routine chest x-rays made up about 68%, 1,082 orders, compared to 32%, which were indication-based. In conclusion, a disproportionate amount of chest x-rays ordered for our trauma ICU patients were ordered as routine or not indication-based. Using our data, prior studies have shown that 22% decrease in number of chest x-rays ordered after implementing an indication-based ordering protocol can decrease it about 22%. Applying this would be $69,828 to $139,000 in reduction of costs. Our limitation of this study is the reliance on the ordering box as to the physician or the nurse, whoever put in the order, to put in this is post-procedure or if this is a daily chest x-ray. And our future directions are to educate the trauma ICU staff on the low diagnostic yield of daily chest x-rays, discontinue that practice of ordering daily chest x-rays, and implement a checklist to reinforce the importance of indication-based orders. These are my references. Any questions?
Resource utilization, hot topic anywhere you go. Dr. Zabari?
Very good paper. My only question to you about cost and charges. You know, you get a CT probably for $400. And if you look at a chest x-ray to say $200 to $400, I'm not so sure if there are charges or costs, so you need to differentiate between them. But good paper.
Radiologic, the X-ray interpretation charges.
I think this is one of the last presentation that was made, and I gave a comment. I want to make a little bit more. It's a simple study, but very important one. And chest X-ray is not the only one that we are using a lot. So even protocolized things are good, have some advantages, but we have to remember to use our brain. We are physicians, and it's in our hand to order what and not to order what. Always think about what you're ordering is appropriate or not, as you are mentioning here.
Couldn't agree with you more. Algorithm-based medicine, they think that EPIC is going to help save money. If you have unabated coagulation, fibrinogens, and I see fibrinogens on the post-cardiac patient that's ordered 4 and 5 days, it totally drives me crazy. so cost inefficient when you think about the implications of cost containment. Sure.
Excellent presentation. One thing when we're driving for cost effectiveness and efficiency is to make sure that we don't also have issues with the quality of our care. And I know this wasn't the focus of your study, but it'd be interesting to know, and it may lend credence even to your results, is to look at these daily chest x-rays and to see what % of them had actionable findings.
Sure.
Because if you have it where none of them had actionable findings, then you've just completely proven your point. But if 10% of them have actionable findings, then you need to get into the debate of what is the dollar sign value of identifying these things and having better patient outcomes.
It's a great point. I would go so far as to say is that new findings, not just findings, but new findings, and how will you change healthcare with that patient as far as that's concerned?
Yeah. I couldn't agree more with Miles. I mean, what's the cost of doing a chest x-ray, which shouldn't be $400, by the way? What's the cost of doing a chest x-ray or not doing it and then keeping the patient in the ICU one day longer because you didn't pick something up? And I would submit the cost that unless you can prove you've got almost zero findings, that you have to look at this both ways.
Just because we've always done it that way doesn't mean that's what you should continue to do. All righty. Any other comments or questions? Yeah.
Question, does that cost include the cost for the radiologist to read?
That's from the literature that I read, this encompasses it all. Yeah.
Okay. Yeah, they don't make as much as they used to read an x-ray. It takes them an average of 45 seconds to read, and they used to make $250. Now I think it's 30 to 40. That's what they deserve anyway.
I think it doesn't matter even it's $1. If you put them all together, it will become important. So even $1, if there is no advantage of doing that one that you are proving, it should not be done.
Couldn't agree.
You have to think about that.
That's great. If not, we'll get you to vote. Not on just favoritism and friendship, but on actual merit. And we will collect these. We'll take a short bathroom break, and I'll give my talk, and we'll move forward with the fun part.
Since I'm done with my research, I'm still working on that. But I promise to come back.
Thank you. Thank I know that it's going to be so early, but our lab's going to get
I did. That's why I was late today. Likewise. It's easier than that when you do it.
Until they have clinical something, like.
See, I'll do something. Yeah, they tell me they were shit.
Well, you know, I watch it the next day and I say, okay.
Back to home car.
Oh, you got it.
How's it going, Chad?
Listen, I don't even have to do my
I want to give you some back.
Bullet points very fast.
I was like, guys, wait, don't fuck with me. You got me right in. Yeah, cool. Yeah, cool. That's cool. What's up? We must be driving past. They said they couldn't go by the window. Got a window down. It went like just full of fuck. We got like 6 7 boxes. It did everything. Yeah, if you do it, there's one of those trucks where you see it. Oh yeah, it's one of those. 18, it's huge. So I mean, so that's what we did. Where? We really got everything. Look, I wonder how much it costs. I don't know, Steph, how much it costs. Anyway. How much? Yeah. You're going to get your
He takes some pictures for newsletter. Yeah, they will be taking pictures. We actual pictures, not just recording. Especially with
But it's not it was like 9 o'clock in the evening. One way to the opposite side, which we went out from yeah. I still can't get used to like parking on the side of the street. Or parking in a parking lot. There's like no parking lot. It's like, I mean, there's a song, but we're going to like. They are the hospital.
So colorful. You'll see, he's very colorful here. He's not from the North Louisiana.
I bet you that would get on the Southern, I bet you would be very well. Look at the historical talk every year. They're often pretty good. I'm trying to get Dr. Sammer to go get on the robotic simulator with me. I can't get him.
Some of the past. They say that if you don't know your past, you're destined to repeat it. And I really went back a long way. My sources for this talk, I have an innate love for history. My mother was a history professor. She loved Huey Long. Everything in our house has mementos of the long period, the long era, the populist movement that was going on in the 30s, 40s, just after the Great Depression. So some of this hit home for me, not only from some of the mementos that I was able to uncover about my mentor, Dr. McDonald, but also about the program. It's not just about LSU. It's about how we've taken care of charity and the indigent and the poor, the decrepit, and those who have not had a place to go to for 100 years plus. So when I started this, which initially started with just a review of LSU surgery, it went so much farther back. I was able to look at archives all the way back to the 1800s. I'd like to thank the Shreveport Times, the journals, the little small books that people donated to antique stores that I bought for an inordinate amount of money. There was one compendium from the Shreveport Medical Society that was published in 1949, which was truly indicative of the history of not only the Department of Surgery, the people who helped man the Department of Surgery, but also the care of charity cases here at LSU and also in Shreveport in general. So this has some surgery. Most of this has to do with surgeons, has to do with the beginnings of all of our training. Some of these names will be foreign to you. Some of them, Dr. Zabari, Dr. Satig, and Dr. Altman and I know, and some of them have passed. As a matter of fact, most of the people that I'm going to speak with are gone. So I won't offend anyone that is currently living. So we'll start with going very far back in the history of Shreveport. Just when did Shreveport start? A lot of the people that are not from Louisiana didn't understand that this is a river town. Well, it really wasn't a river town when it started. There was a log jam about 180 miles that went through the Red River north and south, and the navigation back in the mid-19th century was basically two ways. Horse, buggy, I should say three, pedestrian, and also river travel. Well, the hills and the roads weren't built yet, so there was not a lot of horse and buggies. Pedestrian was very difficult, so that left us with the rivers, and it was locked. Well, there's a guy named Henry Miller Shreve who was brought down, didn't get along with anybody in Shreveport, but was able to knock this large log jam down, and they named the city after him. He never lived here. He moved to Missouri. lived in St. Louis for quite some time. But the town bore his name, continues to bore his name, and the city was annexed in 1936. This is Henry Shreve. He actually had a lot to do with the steamboat, which was indicative of his time, his era, and the mode of transportation. This is a true picture of the logjam. There were dead horses, dead cows there. It was stinky. Mosquitoes were coming out of it, just a ton. And 180 miles in a steamboat very similar to this. It was furrowed in the middle that allowed them to clear this logjam. It took quite a long time. But when people work construction, they get hurt. When they're around mosquitoes, they get diseases. When they're not fed, they need doctors because of malnutrition and some of the other problems. So our early physicians came not for Shreveport, being Shreveport, but because they wanted to come and make some money here. Most of these guys were near retirement. They wanted to come to Shreveport because it was fertile soils from the Red River. There now was a true city itself, and Dr. Ambrose Clark came from Ohio not to be a doctor, but to be a plantation owner, to be someone who's going to make money with agriculture and things like that. So the Shreveport Medical Society started as the North Louisiana Medical Society prior to the Civil War in 1850s. A lot of doctors got together and say, hey, we need the union. We need to be the union. We need to sit around and drink some scotch, smoke some cigars, and talk about what we do. Initially, they were farmers, planters, militiamen, both from the Union and the Confederate side on the Civil War. They relocated here not for the oil, not for the gas. That was nowhere to be found, but because of the agriculture and the propensity to ship this to New Orleans and beyond. So that's what brought them to Shreveport, not LSU Medical Center and things like that. They started treating their neighbors. Soon they started treating each other. And before long, they had formed coalitions. And the yellow fever epidemic, which had hit Louisiana in the 30s and 50s, hit with a vengeance in the mid-1870s. Killed almost 1,000 people. For a town that had basically 12,000 people, 1 to 2 in 10 were killed because of yellow jack, which was the nickname for yellow fever, which is transmitted by mosquitoes, obviously. And it took almost 100 years to figure that out. New Orleans, likewise, was inundated with that disease process. So if you have doctors, you got to have hospitals, right? Well, these were lean-tos. These very early hospitals were basically in the middle of pastures. They were old schools. They accommodated 20 and 30 patients. Nothing surgically was done at that time. There was no avenues other than just maybe I&Ds or amputation without anesthesia, which was done in the Civil War. But the first mention of any kind of appropriation is that the Shreveport needed to help taking care of the needy. Predominantly poor population in Shreveport at that time, a very transient population. And they sent this down. Caddo Parish had just been annexed. The city of Shreveport had just been annexed. They said, we can't take care of this. We've got to get the state. So everything went to the state of Louisiana, and that's where the appropriation started to take care of the charity, to take care of the poor back in the 1870s, not in the 20s and 30s like most people thought. The first hospital that was mentioned was in 1876. It was segregated, as most hospitals were, until the 1960s and 70s here in Shreveport, and it was a pasture known as Moss Side. It was on Ford and Pierre Street. I actually drove down here to see where this is. It's in Allendale, near the Allendale Ledbetter Heights subdivision. I was pretty nervous about being down there, to be honest with you. Pretty high crime area, and I can imagine how much trauma has literally come from that area to be treated by us. It was the site of a previous private school. It was log and frame buildings made with hewn, big, large logs from native forest here around Shreveport. So there were several different hospitals. There was no hospital that was delineated as Louisiana Charity Hospital initially. One of the first hospitals that had a house of ill repute near the same area that we discussed. She had a change, and she saw these people dying of yellow fever, and she says, I got to change my ways. She goes, this is something that I do as being a prostitute. So she actually became a nurse, self-taught nurse, and later on went on to nursing school and donated her home where several patients were treated in Shreveport. Howard University was an association here in Shreveport that was adamant in treating the infirm. They got collections from people that were plantation owners here in Shreveport and was able to help with her home to integrate it into a kind of a makeshift hospital. There's some controversy about were these all one in the same hospitals? We weren't sure, but there was a lot of people now that the Red River was opening, moving up and down the Red. They were getting hurt, logs, getting infectious diseases. So the Marine Hospital was started by the U.S. government, and they saw a lot of patients. Between 1869 and 72, 30,000 patients. There was no private hospital to speak of other than just home visits from doctors that they liked or people who'd moved in for wealth. So they opened this up. 1872, Charity Hospital was first mentioned. And we're not sure if it was an analog of all these or one of these hospitals. There's no pictures of it. It's just briefly written in 1870 by the Shreveport Times. First trained nurse was not long after, and you'll see that that's the case, that the nursing training went right along with a lot of the surgical training. Here's the first notice in the Shreveport Times in 1872. It shows meeting of the Board of Administrators of Charity Hospital in capitals, which means that it was going to be incorporated into the state of Louisiana. Was present by these, Mr. Stoner Avenue, some of the people that have some names in Shreveport, that be it resolved that architects and mechanics who desired to do, though, put a bid in. We want to build this hospital. We want it to start from scratch. The physicians had a chance to review the architectural plans and also the plans and location. And this was sent to Baton Rouge. We continued to repeatedly ask the state of Louisiana, and this is a theme you're going to see for the next 150 years. Didn't start with Huey Long, didn't start with mechanics and politics of Louisiana. It started that Louisiana's been poor, and it's always been poor. We've asked for money from this hospital all the way back to when it was on Texas and Murphy Street for appropriations. Just let us help take care of the sick. Continued problems, and that's why you'll see the evolution of where we are now. They had add-on buildings. They had fire hazards. It was not fireproof. They had no morgue, and a lot of the corpses had to be placed in a shed and covered for several days. Salt was placed on them so they could preserve them, and then they were taken to their loved ones where they were usually buried. We had the capacity for 68 beds, but we had thousands of patients' contacts. We had no pest house. They used to call the pest house was the house where there was communicable diseases. We had to sit people next to people who were clean and did not have contagious diseases. An operating room was built. It was much bigger than what we had right now. As a matter of fact, the early operating rooms were huge, 3 and 4 times the size that we have now, and you'll see that in antiquated operating rooms. There was already controversy about who they're going to take care of. They didn't want Texas people, even though we were very close to Texas. They didn't want Arkansas or Mississippians. As a matter of fact, there was a patient that came here that was drunk, that got stabbed back in the early 1900s, that we wouldn't take care of him. The patient got on some sort of transportation, headed to Charity in New Orleans, and they took care of him there, and there was this horrible paper written, or I should say article written in the Times-Picayune about how Shreveport wasn't taking care of the people that they had. Thus, the kind of the rift that we have between LSU New Orleans and the Charity Hospital system down there. 75% of the population is south of Alexandria. So we really had to fight for any expenditures, both from educational and patient care over the last several decades. The new hospital was finally built on Texas and Murphy. Dr. Sammer and I went out to eat lunch the other day, and we rode by there. It's the City Hall. It's up on a big hill. And the reason why you lived on the hill back then was to stay away from the low water, the water where the mosquitoes were. That's the reason why you see, not only in Rome, but in Paris, that the elite lived on the hills, and unfortunately the poor people lived in the valleys, where water was stagnant, things and pests were ever present. So the new Charity Hospital was in 1904. Had 180 patient bed capacity. There were 6 wards. There was a training school for nurses. In 1911, they treated 600 patients a month. We had 29 cents per patient. Charity Hospital in New Orleans got 70 cents per patient. So we don't know why, but we were high in teeth already. And it hadn't stopped. Okay. There was a large fire in one of the wards in 1926, which finally the state of Louisiana said, okay, you've had a fire. Okay, you don't have a pest house. Okay, your morgue is overridden. We may give you some appropriations for a new hospital. But this hospital was there from 1904 to 1930. We added on 454 beds. There were so many patients waiting in the halls, in the EDs, just like now. Tons of patients waiting to get beds at Charity Hospital. There was no screens. The residents had no running water. T.E. Shumpert, who really started Shumpert Hospital, bought water closets for the residents, gave them beds, and put some screening on their rooms so they wouldn't get yellow fever or all the other problems that comes with unfettered access to a room. There were no screens back then, but they did have the ability to buy 300 fly swatters. Matter of fact, fly swatters lasted for quite some time in the charity hospital system in Louisiana. Here's the first hospital in 1904. They couldn't believe that the state was going to allow to build this. The problem is we had a nice facility, but we had nothing in it. We had not enough manpower. We didn't have enough instrumentation. So while we had a beautiful facility, it was not manned appropriately. This is another picture of it here. You can see the Pullman. Shreveport had a very advanced electrical car system. Horse and buggies and electrical cars were the mainstay. You can see the horse and buggies here, but the pulley system, the people that had started developing oil and gas started developing a pulley system, electrical cars, and was one of the most advanced in the United States. And that's how people transmitted themselves to Charity Hospital, sharing their disease process in the charity car along the way, along with their liquor. And this, of course, is a postcard. Always had it nice and beautifully in color for the postcard. So once again shows they had nice, beautiful fountains. They had iron gating here, very much like Charity Hospital in New Orleans. What did we see? Okay, 1904, 1902, had an average census. And this is not just surgery. This is medicine and surgery. Showed our census here. If you add all of this, this is about 5,000 patients with roughly a census of about 400 a month. And if you look, just like here, during the times of trauma, there was a ton of trauma here. 30% of admissions were trauma-related back then. Now it's about 15%. But also they treated hernias and things that we treat as outpatients. Obviously, they could have a hernia stay for 2 weeks. So during the warmer months, census went up. During the cool of the fall and the spring, census went down. Has a lot to do with pests and mosquitoes also. First surgeon. Pretty tough looking, huh? This is him. He was actually the son of the city commissioner. You'll see a lot of nepotism in medicine in Louisiana. Nepotism at every level in the state of Louisiana as far as the hospital boards. If you knew somebody, they didn't care what kind of surgeon you were. We wanted you to be the supervisor and the chief surgeon. And that's transmitted not in just Louisiana, but Mississippi and other areas like this. He mostly did amputations, simple operations, drainage of pus, but there was not very much anesthesia, you can imagine it, during that time period. This is 1904. This is the chief surgeon here, Dr. Randall Hunt. No relations to the trauma surgeon in New Orleans, but these are the nurses, these are the physicians. I'm not sure where this guy stood in here. He may have been the chief of surgery, I don't know at that time, but these pictures were from the Times, the Shreveport Times. It was very much enamored by the city of Shreveport. The rich, the poor, the middle class loved Charity Hospital. They were proud of it. They were proud to take care of their poor. There was class delineation, but nothing like it is today. There was disparity, but they wanted to take care of everyone there, the rich and poor alike. And so they donated a lot of money to charity. Benevolency was very important in Shreveport and in New Orleans for perpetuation of their charity hospital system. So once again, we kept asking, can you make this hospital fire-free? Can you put fireplaces in? Can you take open heaters out of the wards? Well, they didn't listen. And in 26, a large fire came out. 220 patients had to be moved. No mortalities. The doctors came. The mayor came. Everyone from the city came to help move these patients. The rich came and the poor came. So once again, citywide love for this hospital. This is the new iteration in the 30s. Everyone was so proud. Look at the number, all dressed in white out in front of their hospital. This is residents, nurses, administrators. It looked like the Mayo Clinic. Everyone had white shoes and white coats and wore white scrubs. This is in the remodel hospital after the fire. The state of Louisiana finally listened and said, hey, we've got to put some money up in Shreveport. People are going to burn it. It's going to make us look bad in the newspapers. There was a big article in Baton Rouge and New Orleans how we had to send some more money up. We had to increase that 29 cents per patient up to about 50%. Huey Long was near his peak in power at this time period, but he did not like Louisiana. He was a governor, he was a strong senator, and although he was from Winfield, he could not manipulate the politicians up here like he could in Baton Rouge and Alexandria and New Orleans. So without political manipulation, you didn't get any money. So the state was locking Shreveport down for quite some time. The germ-ridden tuberculosis ward was burned. This is where the pest house was, where a lot of the patients with communicable diseases were kept. They burned this down to the ground, and there was supposedly some great party after this occurred. This is it from an aerial view. I don't think they had drones back there. I'm not sure how they did this, but obviously it was an early airplane that flew over Charity. Pretty big place. Pretty strong looking. You ought to go by the Texas and Murphy Street. The city hall here is now. Here there's a jail there, but beautiful locale. Once again, not appropriately manned or equipped. They had a big party. The new hospital. They replaced the burned down ward. This is one of the surgeons you're going to find out was truly a roustabout, a true tough surgeon guy, and I'll tell you in a little bit why he was so tough. But he demanded respect and he demanded money for his new charity hospital. He was a superintendent. Guess what? He was a surgeon in charge for quite some time. Mr. Sanderson, and you'll see more about him. So they invited everyone out, and even the children could come. They also had events. They had fairs. They had people to come in for circuses. As a matter of fact, one of the trauma patients that I saw, the circus was in town to make money for LSU, for Shreveport Charity, and a lion got after one of the trainers, bit his arm half off, and the surgeons had to take care of him. And the fair left and didn't make any money for LSU. Actually had a debt since they had to take care of the trainer. They had the Opera House, which was the analog of the Opera House in downtown Shreveport, had Damon and Pathology, and they made probably about $600 or $700 for Charity Hospital of Shreveport at that time. First operating room here. Earlier at the previous hospital, they had no lights. Anything at late at night, they had to use flashlights and things of the sort, head lanterns. First Shreveport Hospital had operating room nights where they could do trauma at night. An anesthesiologist had no mask. The head nurse had no mask. She looks pretty tough, doesn't she? And you had to move the table by yourself. Well, just like New Orleans, we wanted to educate our surgeons. This is actually one of the surgeons in New Orleans that had the teaching rounds, the bullpen, so to speak, in New Orleans. And this propagated to North Louisiana. Since a lot of the guys, there was no medical school, yet all the people that were up here were Tulane graduates. Everybody came from Tulane to propagate the surgeons throughout Louisiana. There was no LSU grads until the mid-1930s. But so we had in Shreveport had our own version of the bullpen that took place in Big Charity. This shows here the lights. These teaching instances where the patient was brought down, the visiting surgeons would come, usually at 7 o'clock in the morning on Friday. They had private practices in Shreveport, but they came to the Charity Hospital, either to the morgue or to the operating room where there was an amphitheater and had teaching cases. It was one of the earliest bullpens known to mankind, known to Shreveport, I should say, but very similar to what they had at Tulane and at Charity in New Orleans. Well, not everything was hunky-dory. We have had 2 murders in this hospital that I could tell. Dr. Teague and I knew one of more contemporaneously in 1984, where there was a prisoner who was being taken care of. The family parked a gun. The prisoner took the gun and shot one of our workers here at LSU in '84. That didn't happen. That was not the first one. There was a young attendant who was very hungry after moving patients all night, came down to the cook at the Charity Hospital, Shreveport Charity Hospital that I just showed you. He was hungry, and the cook was a brute, big dude, really upset all the time, kind of a bully. The young man asked him, I said, look, I want to eat. He goes, it's after 8, you're not eating. Well, they got in an altercation. He was stabbed with a kitchen knife, a bread knife, and died. The chef took off and was later hung or shot under auspices of different situations that we'd like to talk about, obviously, today. But we had a lot of trauma here, and I think these are just 2 of the deaths that actually occurred in Charity Hospital, but I think there were more if you truly look at the nature of who attended here. So what were some of the other area hospitals? Well, Shumpert, T.E. Shumpert, who was actually one of the chief surgeons here, started a sanitarium exactly in the location it was. It originally started on Texas Avenue in a hotel, but moved to Margaret Place in 1898. The Sisters of Charity took it over and basically has run it ever since until its closure. And it's so funny how one thing comes around and goes around that we now own Shumpert Hospital. North Louisiana Sanitarium was owned by a Dr. Louis Abramson, who was the father to the Abramson lecturer. This was actually Doctors Hospital up on the hill where Willis Knighton now has the rehab center. This is Louisiana Sanitarium. This is one of the private hospitals that made a lot of money for Dr. Abramson and his son. Highland Sanitarium, it was made in 1917, was also a private hospital on the hill of Marshall and Highland. Still a beautiful building that still exists. You ought to go by and look at it. And then Tri-State took care of the hard-working people on the west side of Shreveport, the glass makers, the industry people who came under the auspices of Dr. Willis and Dr. Knighton in 1926. Shrine Hospital actually was here on this campus before we were. 1922, 6 beds were open. Dr. Abramson was a big El Karuba temple guy. He went to Seattle, made a bid of $450,000. We could run it, and they opened the first Shriners Hospital in this area in the United States. Very interesting. Tuberculosis was rampant then. In 1914, the Charitable Women of Shreveport opened a tuberculosis hospital. There were several in the state. Later on, it was taken over by LSU proper, and this is where a lot of the young chest surgeons started their first lobectomies, segmentectomies, and treatment of TB. And that's how a lot of the early thoracic surgeons were trained in tuberculosis surgery. Not uncommon here, but also in Boston and large big centers where there was a lot of tuberculosis. And in P&S on Line Avenue, where all the spine centers are now, was a hospital for quite some time. What talk would be complete without Huey Long's and his influence on medicine and education, road building, and the poor people of Louisiana? He was a populist Democrat from Winfield, Louisiana, and ruled this state for quite some time. Not in a great fashion. Not in a great fashion. Although my mother loved Huey Long, the more I read about him, the less I liked, because he truly bullied people, but he got what he wanted, and he got what he needed for the poor people of Louisiana. And that's who he campaigned to, and they reelected him overwhelmingly almost with every election. So what about charity in New Orleans? Well, Huey Long wanted a hospital in New Orleans, and he fought tooth and nail at the legislature to get this done. Shreveport Charity Hospital was withering on a vine, but in 1931, these are the plans that he had built for charity. He was assassinated in 35 and never saw the end point of Charity Hospital, but he had everything to do with the formation of Charity Hospital, and he manned it with all his cronies. Surgeons that were not so good surgeons, people that were not necessarily good administrators, but he wanted to run that hospital with an iron fist, and he did, and some of his progenitors did after he died. Dr. Vadrine was a surgeon from Ville Platte who never really formally trained, but was a good old boy. Dr. Long hired him, and when he got shot at the Capitol building, he called Vadrine to come take care of him. Well, he operated on him, and they fixed a little hole in the colon, but they didn't explore a retroperitoneal hematoma with his left kidney, and they closed him up. They were in the operating room 1 hour, and he died about 30 hours later from continued retroperitoneal hemorrhage. A urologist came in and said, hey, this guy's been shot in the kidney. Took a big hypodermic needle, put it in his retroperitoneum, and got frank blood. They said, well, we're not going to reoperate on him. There's no way I'm going to be reoperating on the governor. And he succumbed to an injury that would have been easily fixed had the surgeon been persistent and explored his retroperitoneal hematoma. So Louisiana was one of 2 states at that time that carried a lot of charity hospitals that propagated over the course of several years. Charity Hospital, its first beginnings were 150 years prior to the Shreveport Charity Hospital. 1935, 1936, the big charity, the big free, was built. Later on, we had a hospital in 1930 that we were proud of, and as we move forth, they continued to amass the charity hospitals at almost every location. And the state of Louisiana had a huge budget to take care of its poor, of its charitable cases. And you can see here, I won't go through each one of these. But this is Conway, which started in 1941. There were 3 medical schools. Tulane antedated almost all of these about 100 years. So that's why you see Shreveport surgeons early on were populated with Tulane surgeons. You say, well, this is LSU Charity. Why didn't we? Or this is Shreveport Charity. Why weren't we producing surgeons at that time? Because we didn't have a medical school until the early 1930s. And the school in Shreveport, after almost 30 years of fighting to get it up here, was finally It came to fruition in 1965. The Hill-Burton Act, after World War II, allowed millions of dollars for hospitals to be built. There were a couple of landmark studies that showed there were going to be a paucity of doctors. They wanted hospitals, and they increased the medical school numbers by that time. So tons of money went into that. And part of the government's plan was to build these hospitals in places where the charitable population could be taken care of. Louisiana was one of the first few that took care of them and paid for them. Most other states had privatized decades ago. So while we privatized in 2014, privatization of academic health centers and charity care has been going on since the 20s and 30s. So we're a relatively late comer when it comes to that. This is the original plans for Confederate Memorial Hospital that was built in 1949 and finished in 1953. And if you look, this may be difficult to see, but the floors are the same. Third floor is surgery. The 10th floor is psychiatry. The interns' rooms, which is spelled in the French method of E at the end, is on the 9th floor. So since 1950, not much has changed with this hospital. And the hospital that you make rounds in every day, except for the K-wing, which is over here, is pretty much the same hospital. At least the guts are. There's been some new board placed here and some new walls placed there, but this is still the administration building. This used to be the walk-in clinic. Dr. Teague, remember the walk-in clinic? This was an opened, just come as you can. People would sit in room 2 or 3 times this size and wait 8 hours to be seen for something. Huge amount of transmittable diseases could occur, and not a lot of you remember the walk-in clinic, but I sure do as a med student here. Dedication program was attended by everyone in 1953. 3 governors who helped with this, Jimmy Davis, Earl K. Long, and Governor Robert Kennan, and every band, and Clyde Fant, the mayor of Shreveport, was there. This is the finished product without the medical schools. Medical schools here. The School of Nursing is in this area right here. This is the parking. Looks totally different than what it is now. Medical school didn't come for quite some time after that. So who manned the surgery department? Who manned it? Who took care of the patients? Back in the old location on Texas and Murphy, there never were any surgeons that stayed in-house. It was all residents and intern run. So they would make rounds occasionally. They would make rounds when they needed to. But they all had private practices. They all had practices that they were tending to at Schumpert, North Louisiana Sanitarium, the Pines, physicians and surgeons and doctors' hospitals, and they'd come help the resident as needed. There was no beepers, there was no phones, cell phones I should say, so they had to call those doctors. And you know what? The standard of care was very good. The mortality between 1930 and 1950 of surgical patients was 4%. Total, you would think it would be 15 times higher than that. But if you add up the mortality of all the big cases they were doing, including a lot of trauma, it was 4%. Pretty impressive. This is one of everyone came out, in the old days, that people would put out ads to say, we believe in you, we love you. There was no text, there was I don't think there was very much TV back then, but they talked about the underprivileged is fortunate. We believe in the medical center badly needs service for the less fortunate. Shreveport was engaged with taking care of their sick and their poor. This is the new operating room, Confederate Memorial Hospital, and as you can see, by any standards of today, these walls still exist behind newer walls. Kevin will tell you that. This looks like some of the operating rooms that we did some early trauma in. Okay, where did we list as far as big hospitals in the 50s? Well, if you look at this, Cook County is right up there with 3,300 beds. Charity in New Orleans had 32 beds, 3,200 beds. Shreveport, for a town its size, had 888 beds at that hospital. Now we man 400 beds. But huge amounts of trauma at that time. You think trauma's new? Trauma's not new. Trauma's been coming to this institution since the turn of the century in 1900s. And the mortality has always been favorable. If you look at Louisiana in totality with all the 10 charity hospital systems, we had almost 5,000 beds for the indigent. Not bad per capita at that time. Now, if you look at the population, it's extremely poor. Tri-State Medical Society was a huge medical society, as Shreveport was, and it was also another medical society called 4th District, which had 7 parishes around Shreveport that loved medical education. We had the ability to teach doctors from all over this area. People were coming to Shreveport as this was the epicenter of surgical education. This was a tri-state medical foundation symposium that was in the 50s. This was at Confederate Memorial Hospital. Basically, the visiting doctors would come and they would look at the experts do a cystectomy or a cholecystectomy or an advanced hernia. No mask. They just set up in a little amphitheater and watched them as best as they could. There was no evidence of any video, things like that. But this was a tri-state, and they had these probably twice a year here in Shreveport. All right, quiz time. We've got 3 doctors up here. You know 2 of them. One is a third-year resident that won the Abramson Award for the best surgical resident. Still works, still practices. Very prolific surgeon. Second one is the only 3-time winner of the Intern Award, the award third year by Dr. Abramson, and also the Alumni Award. Okay, raise your hand if you know who this is. Bill Norwood. Willis Knighton. Raise your hand if you know who this is. Dr. Griffin. That's right, Dr. Griffin. I hope he's on the YouTube right now because we're proud of you, Dean, and this, you're pretty cute back then too. So, just like you are now. So, okay, most of you got it right. 1946, American Medical. He's unidentified. As a matter of fact, they had the name switched. I don't know who the other surgeon was. Good question. I'll try to find it for you. Yeah, maybe, yeah, I bet. American Medical Association reviewed our program for the possibility of board certification or having an American College of Surgeons and an AMA certified surgical program. We weren't certified until 1951. Internal medicine was certified in 1946. So we were the 4th one at our hospital to be certified. Kind of upsets me. We want to be number 1, obviously. But the American Medical Association came down to look at Shreveport Charity Hospital. This is when it was on Texas Avenue. Showed the number of cases. A lot of tumor, a lot of surgical oncology back then. 5,000 cases when they did the review. General surgery cases, 4,500. GYN was done all by general surgeons then. Otolaryngology, a lot of cases. Part-time radiologists, we had no part. But the pathology was exceedingly strong. Dr. Matthews was here for decades. Was one of the well-known world figures in pathology, was here in Shreveport. Here's our surgical staff. Dr. Hurd, the first gentleman on the wall, the east wall that you see over there as surgical chair. Paul Abramson for this lecture or lectures like it that was named after him. Dr. Wallace Brown, a very prolific surgeon that was at Shreveport Hospital, came over here during his early training. And here, Dr. I'm trying to think one more. I think that was it that I had known. You look at the residents and fellows. Charlie Black, one of our chairs. Dr. Gladney from Homer, Louisiana. It's not the Dr. Gladney, it's one of his relatives. And Dr. Overdyke, who has orthopedic connections here. Some of the early surgeons. But something that I'm not sure if anybody knew that I saw in this paper that I had to really get my spectacles on to see was in the black here. This is what the residents made, 60, 100. And it says representatives from Tulane University School and Hospital are trying to form an affiliation with this residency program. Tulane wanted this program. They wanted it a long time ago. They wanted it to be named not LSU, they wanted it to be named Tulane. So I'll tell you a little bit about that later on with Dr. McDonald's connections to Tulane, but this even antedated him. So Tulane was interested in having our medical school way back when. Separate but equal, if you look at Cook County, you look at Charity Hospital in New Orleans, you look at LA County, that these were structures that, sad but true, the government would give you appropriations, but you had to have availability of services for all colors and creeds. So what the states did back then, which was a horrible thing obviously, is that they created 2 wards. Wards for the whites and wards for all others, which is luckily and now a thing of the past. But it's amazing these structures were built for form and function, that there were several wards that were segregated. And luckily and gladly this changed. At the at the very top level. They were getting the monies for these wards, but they weren't getting the care that the other wards got. Luckily, that's changed. And it changed very early here. You would think that a hospital named Confederate Memorial would not have changed. They would have been resistant. But Shreveport, I thought, was very proactive in desegregating the hospital wards way earlier than Mississippi and even New Orleans and Baton Rouge. So Confederate Memorial Hospital was transferred to LSU in '76. These are some of the name changes. LSU Hospital Shreveport, LSU Medical Center, LSU Health Science Center, of course, E.A. Conway in 1941, University Health. Someone's doing this talk 15 years from now or 20 years from now. We're going to have some interesting things to say about this time period. Ochsner and also St. Mary's, which is just added in the last several months. State of Louisiana started saying this is sticky. We're losing money on charity care. Now they started not thinking with their hearts and souls of the people of Louisiana, they started thinking with their pocketbook. They started diverting the responsibility of the charity care to Health and Human Resources, Healthcare Authorities by Edwin Edwards, which were all cronyism, turbulent period. And finally, LSU had to take it. They didn't want the hospital system, but LSU was mandated to take it at that time. 10 charity hospitals to be taken care of by an academic health center. Didn't seem right, and you're right, it's not. It hurt all the academic health centers. There was a lot of turbulence, cronyism, favoritism, and the governors, not only Huey Long, but those thereafter, used Charity Hospital in Shreveport, Charity Hospital in New Orleans for their personal favoritism and some of the things that they wanted by basically appointing people to the boards so they could have power of the hospitals. Not necessarily the best people to run the hospitals, but they were the favorite for the governor of the time. Okay, quiz number 2. Obviously some young ladies playing badminton. Can anybody tell me where this is located? It also took place where residents would sunbathe, occasionally drink beer, unbeknownst to the attending. What? Nope, wrong, not the helipad. Administrative building. This used to be the old nursing school. This is the administrative building. And they would take the net down and sunbathe up there. Back when it was in vogue to do that, the residents would go up there and have stickball games, amongst other things, and I heard that there was some beer up there occasionally too. So this is the top of the old nursing school and the charity hospital, or excuse me, the nursing school. All right, we're going to change courses a little bit. We're going to go over the chiefs. Now, there's a lot of names. This has never been done before. Nobody's ever taken the chief from 1876 to 2020 and counted them. They've also not checked how many residents we've trained from 1876 to 2020. Now, I must tell you, there's some lapses in records, but I think I'm pretty close. So we looked at this, and I had another elderly surgeon look at it to help me for completeness. So hopefully this will give you an idea of how many surgeons have come out of Shreveport. Not out of LSU Shreveport, but out of Shreveport Charity, Shreveport System, where we live now. So we're going to go through these pretty quickly. Dr. Clay, I don't think this is any relation to our Dr. Clay from Conway, but nonetheless his name's up there. T.E. Shumpert was a very talented surgeon. He was an elite surgeon. He trained at good places. He was a vascular surgeon. He was a thoracic surgeon. Nobody had a specialty. You did general, thoracic, and vascular. If you didn't do it all, you were delegated to the minor hospitals of Shreveport. But he was good. He trained at the private hospital Thatcher here in Shreveport, at LSU, University of Louisville, NYU, and he returned to charity. He was the first one in the United States to ligate a subclavian artery, proximally and distally, for subclavian aneurysm through a transclavicular approach. This was written up, and you can find this in some of the vascular surgery journals. Unfortunately, he really wanted to be an academic surgeon. But as you know, the charity hospital system has always had a practice plan. So when we're hired by the faculty hired by LSU, we basically get a stipend, and for every patient we have, the hospital bills for it. So we don't bill directly, the hospital does. That's the way it's always been here at Charity. That's the way it's been at LSU. Well, Dr. Shumpert had a different idea. What he did, he says, I'm going to make some money. He said, I don't want to be just a surgeon for the poor. I want to make a little cash on the side. So what he did, he opened up 2 beds at Charity Hospital. This created a firestorm of problems, and he was collecting money from them. And basically, Shreveport says, you're in violation of your contract. You're making money from these patients. We're paying you a stipend. Number one, we're going to cut your salary. He went from $75 a month to $50 a month. So he got upset and he left. He said, look, I think medicine, we can make money from medicine. We can take care of the poor. We can take care of the rich. We can take care of anybody here at Charity Hospital. The governor didn't agree and had him ousted in about 2 years. One of the most talented surgeons who could have stayed here was sent out because of some problems with what was the faculty plan or the way monies was spent there. Some of it was political, obviously. He went on to be very successful at Shreveport Hospital, and the rest is said. He unfortunately died of a hemorrhage in his adrenal gland at age 47, secondary to typhoid fever. Dr. Gray, 1892, you saw Dr. Hunt's picture in the old hospital. He did a nerve transplant, was the first in the North America to take facial nerve, dissect it out, and place an interposition nerve graft. He did that at Charity. He was a Shakespearean scholar, very much like most of our staff nowadays. Dr. Larison treated axillary artery aneurysm. And you can see, whenever the governor would appoint a new hospital board, the chief of surgery changed. Never failed. A lot of political nepotism, a lot of political favoritism. Dr. J.A. Hendricks only stayed a year. He trained at Seminary, Tulane, Johns Hopkins, and the Mayo, and said, look, I can make more money than this. So he went out and formed Highland Hospital, which is probably one of the most successful private hospitals in Shreveport. He did make a mint. Dr. Rue and Dr. Garrett. Dr. Gray's, this is Dr. Gray's son from who you saw previously. Dr. Willis from Willis-Knighton was a chief surgeon. Now these are the surgeons who came in and were the head of surgery for the residents. They came and visited. They didn't stay here. They didn't have an office here. That didn't start till the 70s. E.L. Sanderson was a force to be reckoned with. This guy took no prisoners. He made John McDonnell look like, I don't know, just someone that this guy was tough. John McDonnell was a gentleman. This guy was no gentleman. He was a politico. He was close friends with Huey Long and was actually with Huey Long when he died. He was the chief of surgery for more years than anyone here except for Dr. McDonnell. He had 3 house surgeons, which he routinely fired and hired new ones. He had 11 interns. He had 70 visiting faculty, which he ruled with an iron fist, and he made them rotate through the hospital system. That's where the gown academic surgeons versus the town, the private surgeons, start having little issues, because he would frequently interpose himself in political fights that he knew he couldn't win. He fired one of the previous chair's sons the day he started the job. And when Dr. Sanderson went over to Shreveport to make rounds, which